And coming to today's scientific session, theme of today's scientific session is obstetric protocols. I welcome the chairpersons for this scientific session are Dr. Sunita Subramaniam Madam and Dr. Manik Rao sir. I welcome Dr. Sunita Subramaniam Madam onto the dais. Madam is a graduate from SVMC, that is Sri Venkateswara Medical College, Tirupati. She has done her post-graduation in DGO and MD OBG from Guntur Medical College. She had a training experience of about 41 years. She has trained thousands of graduates and hundreds of postgraduates. Madam was the HOD of the Department of OBG, SC Medical College for 9 years and Superintendent of Government Veterinary Hospital for 7 years. And Madam was Principal or Additional DMA of SC Medical College for 2 years. Madam is a life member of IMA, Executive Member and Ex-President of Talks. Madam was the examiner and paper setter for UG and PG in various South Indian universities. Madam organized many workshops and health camps in the state level. Madam attended and being the chairperson in many state and national conferences. Now I welcome another chairperson, Dr. Manik Rao sir, onto the dais. Sir is a professor and HOD of Government Medical College, Anantapur. Sir was the past president of. Sir was the past president of APOGS from 2017 to 2018. Sir was the secretary for Kurnool OBG Society for 10 years. He was the organizing secretary for 4th APCOG Kurnool. Sir got Best Secretary for Society in Indoor AICOG for 21 to 22. Sir's field of interest is gynec oncology and laparoscopy. Sir was a member of All India Gynec Oncological Committee for 2020 to 2021. Sir was a member of Family Welfare Committee from 2013 to 2014. He was a member of Sexually Transmitted Diseases from 2016 to 2017. Sir was the coordinator for AP and Telangana for Gynec Oncological Committee. Sir got Best Paper Award in 2 state conferences. Sir was the author and contributing author in 2 teacher textbooks. Sir received Best Doctor Award from District Collector twice. And Sir was an MCA inspector and ex-member of APMCI Finance Committee member in combined AP. Sir was a DNB examiner for AP, Telangana and many other states. He presented many papers, lectures in state, journal, national conferences. He had many publications in national and international journals. And Sir was a chairperson in many state, national and international conferences. Sir was consultant in DIA clinics, Kurnool. I request the chairpersons to preside over the function, ma'am. Please, ma'am.
Good morning, everybody. I am sorry, Madhavi. I am not so young. I'm having 41 years experience. You told 21 years. Huh? Okay. Now the speaker, Dr. Susila Vavilala, having experience of 23 years. Dr. Susila has joined Fernandez Hospital in 1990 of the fetal medicine unit. She acquired her fellowship in fetal medicine and became a consultant in 2006. She has been trained various aspects of fetal medicine, obstetric ultrasonography, including Doppler study and fetal echocardiography, prenatal interventions, genetic counseling, and perinatal pathology. Her areas of interest are fetal echocardiography and fetal diagnostic and therapeutic interventional. A passionate teacher organizes the training programs of the department. Department is maternity and fetal medicine. Her qualification is can be fellowship in fetal medicine. Her favorite books are Sandamama, Bhagavad Gita, and both extremities. Her favorite singers are, interestingly, her husband also, Dr. J. Srikant. Apart from him, S.P. Balasubramanian, M.S. Subbalakshmi. Her favorite pastime probably was a Kuchipudi dancer, and she likes yoga. Now I invite Dr. Susi. Go ahead.
Good morning to one and all. Thank you very much, ma'am, for the kind introduction, and also the organizers for obliging my request to have mine as first talk. Well, we all know that fetal growth restriction is one of the areas where we need to have certain protocols because this can lead to adverse perinatal outcomes. This is a beautiful city. We call it as Kaliyuga Vaikuntham. And then this is the first day of the conference after the workshops. I'm sure that once we enter into our own respective work areas, the scenarios that I'm going to share are not too different. Here is a mother, 33 years, second gravida, para 1, live 1, low risk pregnancy supposedly, and she presented to the emergency with the reduced fetal movements. Scan confirmed intrauterine fetal death. I'm sure the seniors here agree that this is not an unusual experience. So the stillbirth is a catastrophic event, a nightmare for the practitioners, and an unforgettable experience for the couple. The baby is here small but normal, unlike anencephaly, where we are prepared for a stillbirth. So thank you organizers for giving me this opportunity of sharing our experience at Fernandez Hospital with the fetal growth management. So one important thing is IUGR is a gone terminology, should be called according to the international standards as fetal growth restriction. So it can lead to up to 30% of the perinatal mortality and then high preterm morbidity, not just the immediate outcomes like neurodevelopmental delays, but if you remember the textbooks, they do mention about the Barker's hypothesis where the fetal growth restriction can lead to long-term morbid conditions which are otherwise called as non-communicable diseases at all. So evaluation of the fetal growth constitutes key objective of the prenatal care. And this is going to be my storyline for the coming 30 minutes. I will try my best to the 28 minutes. But important thing is that there is a prerequisite which includes the accurate dating and accurate measurements as well. When it comes to the first trimester dating, the golden period is the first trimester of pregnancy, and up to 13 plus weeks, that is Fetal Medicine Foundation's 11 to 13 week scan, the CRL up to 84 millimeters, and afterwards, the head circumference, if at all the crown rump length is more than 85 millimeters, helps us to date this pregnancy and calculate the expected date of delivery. But important thing is that if at all the dating of pregnancy is done and expected date of delivery is given, do not change in the subsequent scans. This is one important message that I would like to share from this podium, because in our scan reports, we keep getting that every time the expected date of delivery keeps changing. It is not, because we all know that pregnancy constitutes 40 weeks or 10 lunar months, and therefore expected date of delivery has to be calculated in the first trimester of pregnancy itself, and it should not be changed in the further scans. So this is the beautiful the protocol that we have in our hospital, where we say that first trimester is by CRL, and if there is a difference of more than 5 days, redate, whereas 9 to 13 weeks, difference of more than 7 days, we need to change the date. This particular protocol I'm going to share with the organizers. I'm sure you have a delegate WhatsApp group where the important articles from my study, which are very, very important. I feel that every gynecologist and obstetrician should read these guidelines of International Society, which includes the dating of pregnancy as well. We all know that clinical ultrasound biometry and growth curves are important things to identify a small fetus, and we were taught how to measure the fundal height in the clinics right from undergraduation days as well. But important thing is that measuring the fundal height with the tape and not just leaving it, compare it every time. We have seen that. So 16 weeks, like for example, 24 weeks have measured the fundal height, and when the woman comes back at 28 weeks of pregnancy, again compare where there is an increment in the fundal height or not. This we can discipline ourselves in the clinic itself. Coming to the fetal growth assessment for the ultrasound, the guideline says that in low-risk women, a growth scan has to be asked around 36 to 37 weeks of pregnancy or as late as possible. There's no point in asking for a scan at 26 weeks in supposedly low-risk women and forgetting to do a scan at 36 weeks, where actually in the abroad, they don't have a guideline for the a protocol for assessment of the third trimester scan in NHS or other abroad countries, in UK, etc. But unfortunately in India, we keep scanning these women number of times. But do not forget to ask for a single scan for a low-risk women at 36 to 37 weeks of pregnancy, and in high-risk women from 28 weeks of gestation onwards, that is the salvageability every 3 to 4 weeks of pregnancy. So when I do the scan in the biometry, what do I do? The BPD, biparietal diameter, head circumference, abdominal circumference, and then FL, that is the femur length. All these things were put into the estimated fetal weight, and the standard formula that we all have to follow is the Hadlock's. So after I do the Hadlock measurement and then measure the fetal weight, then what do I do? What do I do is that measure this we have to see that whether it is growing according to the expected standards or not. So when we see your colleague's daughter for the first time, you say that how nice your daughter is, how old is she? But next month when you meet the same person, you don't ask, how old is she? Because you already know how old the baby is. The same way on the scan, if we do a fetus, if you see a fetus, first time we have to date the pregnancy, and all subsequent scans only we have to assess the growth. So this takes us to the principles of the growth measurement, fetal growth. So why is there a disparity? Babies born at the same age or of different sizes, but still normal. All of us are of different sizes, but still according to the age of our own, we are normal, isn't it? So this is leading to the concept of the variability. And as you all know, in the final MBBS, if a student gets 65%, 75% or 90%, we call them first class, second class, distinction or whatsoever. But when it comes to the NEET, UG, PG, what we look at the ranking, which means that according to the peer group, how did this particular child or the doctor performed. So this is called as, what is called as the centiles. So this is different from percentage to percentile. This concept is very important because percentage is how many marks you got, whereas percentile is right from chronological order, where do you stand. So the same way, estimated fetal weight, we have to see where exactly this fetus estimated fetal weight stands. So that is called as percentile. Promise yourself, sir, that from henceforth, when I go back to my clinics, I look at the percentile of the fetus, and so that I can see how this particular baby is growing. So this can be represented as a bar graph or a curve. So in the bar graph, you see the cutoffs, 5th centile, 50th centile, and 95th centile. Also, it can be depicted as a curve. So the lower part is the 5th centile, the middle one is 50th, and the above one is 95th centile. So why do we need that? You can see enlarge. This particular thing is available in all the ultrasound machines as well. If the radiologists are not motivated to give this percentile, push yourself and I say that, ask your colleague, so what is the percentile of this baby? An important thing is that these percentiles are available on the internet free of cost as well. So if a baby falls on a curve less than the lower one, it is called as small for gestational age. If it falls in between, it is called as normal, and if it falls above the above line, it is called LGA or large for gestational age. This concept is very important. These are called the population curves. Also, there is an entity called customized growth curves, where the growth curves are according to a particular patient. So we take this mother's all the parameters and generate the curve for this mother to carry this particular baby to the term, then what are the expected weight of this baby. This is called customization of the fetus to the mother. Whereas the other variety of curves are called as the population curves. So in a general India, how much the babies are growing, in abroad, how much the babies are growing, is these nomograms normal for this particular baby. So this is the customized growth charts, which includes clinical as well as the ultrasound assessment of the fetal growth curves. Whereas it may not be available for all those. At Fernandez, we use this in the clinic, and if the fundal height falls less than the expected, then we would ask for the scan. Whereas in the population curves, these are available online and also in all our ultrasound machines. All that you need to see is that open your ultrasound machines, whoever is doing, and see where this estimated fetal weight is actually falling. So the fetal growth patterns, as I have said, are called appropriate to the gestational age, small for the gestational age, and large for the gestational age. So any baby's weight falling beyond these particular lines, they are called as the small for gestational age, appropriate for the gestational age, and above is the large for the gestational age. So green go means that it is normal, then AGA means that it is a normally grown baby. So in this particular graphs, I have depicted the estimated fetal weight of this particular women at 40 weeks is falling exactly on the 50th centile. So it is between 5th and 95th centile. Hence, it is AGA fetus, appropriate to the gestational age. Whereas in this diabetic mothers, this baby's weight is falling above the 95th centile. So this is a large for gestational age baby. Whereas in this particular mother who is APLA positive, the fetal weight is falling less than the 5th centile. Therefore, it is a small for gestational age. So it is only that opening of your eyes and then mind and then depicting these on the graphs, which gives the small for gestational age. So how do we do this? Take the biometric parameters, plot the growth curves, calculate this growth percentile, and identify the growth pattern. But very, very important thing is the accurate assessment of the gestational age that is done in the first scan is very important. So from here we move on to the fetal growth restriction and then small for gestational age. So the definitions are the growth restriction actually is the failure to achieve the growth potential, whereas small for gestational age estimated fetal weight or AC less than the 10th centile. Why is it important? Because small for gestational age fetuses are constitutionally small. That means they are not pathologically restricted. But life is not so simple. You can see here, I said less than 10 centile is called SGA, and 10th to 90th is AGA, and more than that is LGA. But if you see the growth restriction, right from 0 centile up to 50/60th also there is a fetal growth restriction. Because this definition is unhelpful and then it is very tricky. Therefore, we need the additional methods to qualify the small for gestational age versus the fetal growth restriction. So if the weight of the baby is falling less than 3rd centile, then it is called growth restriction without any additional information. Whereas if you see here a fetus which is growing at a lower level, this is constitutionally small, whereas at 20 weeks it is at the 50th centile. When I saw her at 31 weeks, it is less than 5th centile. So this baby is not maintaining its potential. When do we call it as it jumped the centiles? If there is a difference of 2 quartiles or more than 50th centile, that is a fetus at 70 centile suddenly falling to 20th centile, there is a difference of 50th centile. Therefore, this is a growth restricted fetus. And mind you, here the estimated fetal weight is 20th centile, that means more than 10th centile of our definition of SGA. I hope I am clear in this concept, because fetal growth restriction can still happen in appropriately grown gestational age fetuses. Therefore, this crossing centile pattern, every time you ask for a scan, you see how much centile it has fallen. So how do we distinguish between this growth restriction versus small for gestational age? Age-old textbooks, we were taught that do the umbilical artery Doppler, and if Doppler is abnormal, it is FGR. And then if Doppler is normal, then it is SGA. But life is not so simple. We need more and more information to qualify them between small for gestational age versus growth restriction, which can be done by, as I have said, estimated fetal weight falling less than 3rd centile. You don't need any other parameter. It is a severely growth restricted fetus, whereas uterine artery Doppler more than 95th centile, again it is growth restriction. If CPR, that is umbilical artery Doppler versus the middle cerebral artery Doppler, this ratio is altered and it is less than 5th centile, then it is growth restricted fetuses. So these 3 parameters help us identify what is SGA versus what is FGR. So it is very simple. Look at this estimated fetal weight. If it is less than 10th centile, look at estimated fetal weight, uterine artery Doppler and CPR ratio. If all of them, none of them is negative, then we say that it is small for gestational age. If any one of them is positive, then it is a growth restricted fetus. It's a very easy concept, isn't it? This all of us can practice in our clinics. So we now move on to the early versus late fetal growth restriction. Previously, when we were all students, we were said that asymmetric versus symmetric growth restriction, which is nothing but, the baby's head is big and then body is small. It doesn't work like that. These are descriptive terms and phenotype, which does not have any clinical significance. But what is important is early versus late fetal growth restriction. In a minute, we will cover why early is versus late is important. Early growth restriction, gestational age is 32 weeks and below, in the absence of congenital malformations, of course, either AC or estimated fetal weight less than 3rd centile, or umbilical artery absent end-diastolic flow directly goes into the early fetal growth restriction. Or you can have one of the parameters rest, which we have already seen. Whereas late fetal growth restriction is growth restriction happening after 32 weeks of pregnancy, in the absence of congenital malformations, of course, and again here, estimated fetal weight less than 3rd centile, and at least one of the 3 following features, that is, what we have covered, crossing centile of more than 2 quartiles or 50% jump from above to below. All these things qualify the late fetal reduction. So early fetal growth restriction, here is the Apla mother. We have seen placentomegaly is there. You see all the parameters falling less than the 5th centile, and then Dopplers are also altered. And here, early fetal growth restriction, the umbilical artery Doppler is reverse end-diastolic flow. So directly I can say that it is a growth restricted fetus. Why is it important? Because less than 30% of the placental function, if it is gone, if it is damaged, then there will be abnormal umbilical artery Doppler. And very, very important is that 75% of these mothers have hypertensive disorders. See, the placenta is the connecting organ, we all know. If it hits the baby, it can manifest as growth restriction. If it hits the mother, it can manifest as hypertensive disorder of the pregnancy. So whenever you come across in your practice growth restricted fetus, do not forget to measure the maternal blood pressure. Very, very important message, because in our practice we see them a lot at Fernandez Hospital. Then coming to first mishap which happened, then why did this baby succumb? Because previously it was all right, everything is going all right till 38 weeks of pregnancy. If you see here, only the last scan had a fallen less than 10th percentile, and alters the Dopplers are also normal at that time. This is a very important slide. You can see here the nutritional demands from 20 weeks of pregnancy increase for the fetus, whereas the fetal maturational needs actually reduce, because we know that fetus is maturing. But what is very important is that from 30 weeks of pregnancy, the fetal gaseous demands increase. That means the oxygen content in the blood, and then the requirement of oxygen is more for these fetuses. Unfortunately, till now, we don't have any particular tool to identify how the oxygenation is happening to this particular fetus. And what is important is that for the umbilical artery Doppler to become abnormal, 30% of the placenta should be damaged. Whereas, as we have seen just now, a mature fetus, it cannot stand 30% of damage of the placenta. Therefore, before the umbilical artery Doppler becomes abnormal, these pampered fetuses will die in utero. Till then, they were getting good circulation, but suddenly there is a less oxygen, and therefore the fetus died. This is a very devastating condition for the practitioners as well as the parents as well. So that is why it is important that many tests, including umbilical artery Doppler alone, are not useful in case of the late fetal growth restriction, and it is not accompanied by maternal hypertension because the damage is occurring too fast. So we will move on to the management protocols and then fetal surveillance tests. If you see the modalities, as far as the CTG is concerned, there is a very controversial issue, but Apcog recommends that CTG can be done on a weekly basis for the fetal growth restricted fetuses, definitely on a weekly basis. And BPP, not very useful because what is important is the computerized CTG, which is not available in India yet. Then amniotic fluid index, inclusion in the management protocol is questionable. Then what are we left with? We are left with the multi-vessel Doppler, which includes the arterial as well as the venous. So this is the best guideline which is available free of cost in the subscription. In the net, you all can download and read wonderful guideline that we follow at Fernandez Hospital. So the Doppler, where the wave pattern is actually signature. The systolic and diastolic ratios. Do not look at RI. What is important is gestational age dependent pulsatility index is very, very important for our management in these cases. And as you see here, the umbilical artery Doppler, normal, high resistance, absent and diastolic flow, and then reversal of the flow where there is cardiac pump abnormal as well. Whereas when it comes to the middle cerebral artery, because baby is trying to preserve the brain, the vital organs, the brain, adrenals, myocardium, etc., in preference to the rest of the splanchnic circulation, and therefore more and more blood will go to the brain to preserve the function. So MCI is called as a darling vessel for those who scan it because it's very easy. I don't know how to scan the adrenal artery of the fetus, but I know how to scan the fetal middle cerebral artery. Therefore, MCA has come into the place. And then other important thing is the ductus venosus. As you understand, as the pressure increases, placenta resistance increases, there will be high resistance in the DV followed by the reversal of flow as well, which includes the acidosis. And another important vessel, the umbilical vein abnormality in terms of pulsatility with high PI. The pulsatile flow of the umbilical venous, you can see here, it usually occurs as a smooth line, but this occurs, we know that this particular baby is going to die unless we actually plan the birth. So coming to the management protocols, another important slide and then which we practice at Fernandez Hospital is that there are many don'ts in the management of fetal growth restriction. Please do not ask the mother to take bed rest. She may already going into preeclampsia and may develop thrombosis and then may die of, go into the DVT management. And then low molecular weight, heparin and aspirin, in the absence of evidence, a big no, because we know that they all have a lot of complications as well. There was a very roar about the sildenafil, but and then arginine sachets as well, but they are not important. You have to treat the cause, not treat the finding on the ultrasound. So this is the update on diagnosis and classification of the Barcelona. So any fetal weight falling less than 10th percentile, we look at these parameters. We all saw that. If small for gestational age is there, that is estimated fetal weight less than 10th centile, call the women for scan every 2 weeks, and less than 40 weeks, repeat the scan 2 weeks, and induce at 40 weeks. Induction still is possible. This is what the Digitat study also says, that induction is possible in small for gestational age fetuses. Whereas, if less than 10th percentile and one of the Dopplers is abnormal, then it becomes actually what is called as fetal growth restriction. Depending upon the Doppler findings, we call them into stage 1, where the Dopplers are otherwise normal, and stage 2, where there is absent and diastolic flow. stage 3, it is called the reversal endostolic flow, whereas stage 4, ductus venosus reversal also is there along with the fetal heart decelerations. So counseling, steroids, and then magnesium sulfate less than 32 weeks play a very, very important role. The fetal growth assessment at Fernandez Hospital, risk categorization done at antenatal booking. First trimester, check the CRL dating. Second trimester, uterine artery Doppler we do, and screening for fetal growth restriction on the customized growth curves in the clinic. And screen positive, refer to fetal medicine for estimated fetal weight. Low risk women's 35 to 36 weeks and no Doppler. High risk women, every 3 to 4 weeks, depending upon the requirement, they get the estimated fetal weight and Doppler SOS. Estimated fetal weight less than 10th percentile, multi-vessel Doppler we do. Small for gestational age in the absence of any of the Doppler findings. We call them on 2-weekly monitoring and induce at 40 weeks. Fetal growth restriction, any of the abnormal Doppler, we go by this algorithm saying that it is a stage-based protocol. And we will now move on to the coming 7 minutes, quickly, some of the case scenarios, because theory is all good, but practice is something very, very important. Here is a primee booking at say 14 weeks, so she missed the bus of the first trimester screening and then CRL dating. And first trimester scan showed that there is growth restriction. So detailed ultrasound is very important because in 20% of the cases, we may pick up the abnormalities, congenital malformations. Whereas fetal diagnostic testing either by amniocentesis or CVS depending upon the gestational age for microarray has to be taken compulsory, especially in early onset fetal growth restriction that is less than 32 weeks or when the findings do not go hand in hand. Because when there is a growth restriction, I expect the Leica to be less. Whereas if the Leica is more, then something fishy here, so we need to exclude the chromosomal abnormalities. So the Apcog guideline definitely recommends against the torch. Please remember this. But what is important is that polymerase chain reaction for CMV if you are already doing amniocentesis. This is a very strong recommendation from the Apcog guidelines that what we follow here. So for the case we have done the amniocentesis, it's revealed triploidy. You can see here in the slide as well. Then here is the 36 weeks referral in view of fetal growth restriction because we are a tertiary care center hospital. And as we did the scan, all the parameters are falling less than 5th percentile and growth restriction. Do you all agree with the growth restriction here? Very simple, isn't it? But what is important is that you have to review the previous scan reports. Okay? So first step is gestational age determination by the first scan and second step is plotting the growth curves. So when we reviewed her previous scan reports, the CRL there is a disparity of 6 weeks. And when we corrected, so it has become actually she's 30 weeks and not 36 weeks. So this we have extrapolated and hence the growth is totally normal. So it is a normal appropriately grown fetus. The growth curves may mislead you. So you have to date the pregnancy first. We thought that this is a growth restricted fetus, but once we date the corrected, it is appropriately beautifully growing fetus, isn't it? So this is a word of caution, always look at the first scan report. So you get scenarios like this, estimated fetal weight at 37 weeks is 2.4. How do I do this? Google Baya is there, so just Google, and one of the things is that online calculators are available. This is the Barcelona protocol that I have shared, and this is the Barcelona Fetal Medicine Center. And what we do, the parameters that we have put in, we have entered into the online calculator, and once I calculated, it has shown that estimated fetal weight is 2.4, which means 14th percentile. So 14th percentile is more than 10th centile. It is a appropriately grown fetus. Do you all agree with me? So we say that yes, this fetus is healthy and good to go. Then here is another mother at 37 weeks of pregnancy, estimated fetal weight is 2.2, and hence because it appears less, lot of Dopplers are also done, and the growth curve showed that everything is falling less than 5th centile. Even here the bar graph also is showing just touching the 5th centile, and the centile here is 2.6. So 2.6 is less than 10th percentile. That means it is a small for gestational age and Doppler abnormalities. So we have entered this data into the Barcelona calculator, and then it has said that fetal growth restriction of stage 1 and then recommend delivery at 37 weeks of pregnancy. So if you just open your smartphones for a while for the medical reason, go to the Barcelona fetal medicine calculator, fetal growth, and then enter this data. This particular, the protocol that we follow at Fernandez is just a fingertip away from you. Another case here, 26 years, second gravida, hypertensive, and then 32 weeks of pregnancy. I know that umbilical artery Doppler is AEDF, that is absent and diastolic flow already, and we have entered this into the calculator. Then it has given umbilical artery Doppler as the absent and diastolic flow. So the calculator will tell you it is a stage 2 of the growth restriction, and therefore recommendation is follow up 2 to 3 days, give the steroid and then counsel them and then let them be ready for the delivery as well. The case outcome, of course, we give the steroids, magnesium sulfate and maternal monitoring and delivery by C-section if there is absent and diastolic flow. And this is 35 years second gravida para 1, previous baby CP, and then she is 28 weeks of pregnancy. The biometry is all showing less than the 10th centile. This is at 28 weeks of gestation. I expect the baby to be 1 kilogram, whereas the weight is 500 grams. And there is umbilical artery is reversal of flow, and then there is redistribution. Ductus web is pulsatile pattern as well. We entered this into the calculator. It has shown umbilical artery Doppler as the reversal of flow, and therefore it has given that stage 4 fetal growth restriction. It suggested delivery. Now here we have to take a pause and think, oh, 500 gram of baby, am I going to do C-section? I mean, it's horrible, isn't it? And therefore, the surveillance test depends upon the setup that you work. By and large for India, 28 weeks of pregnancy and 1 kilogram is the cutoff to say that I will be aggressive in the management of this high-risk fetus or a pregnancy. Whereas at Fernandez Hospital with the perinatal center and then having a lot of expertise there and a referral center as well, the limits of viability for us are 26 weeks of pregnancy and estimated fetal weight of 750 grams. So this is the area where we start saying that yes, the results are encouraging for the fetus, though it may need a lot of NICU stay, financial, emotional, physical and mental torture as well. So that takes me to my last slide. Fetal growth restriction is one of the causes of the stillbirth. Small for gestational age versus fetal growth restriction, there is a considerable overlap, and sometimes we get bonkers about distinguishing both of them. Diagnosis is not always straightforward, we have seen that, and placental protein markers like SFLET and then PLGF are coming in vogue. These are in the research tools, not at the clinical level at the moment. And Doppler helps us in the diagnosis and management as well. What is useful for us is that the online calculator that we have seen, which gave us a stage-based protocol as a useful tool. I hope that you practice this important thing in your clinics from tomorrow onwards, because it is very user-friendly, and we have international papers published on this particular area as well. It is doing wonders, helping the women and their unborn high-risk fetuses. With this, I take the permissions of the chair. Yeah, I still could stick on to my time, ma'am. Thank you very much. Thank you everyone for your patient listening.
Thank you, Dr. Cecilia Garu, for your excellent lecture, an elaborative one, very descriptive one. And I think we take the questions at the end of the session. Any questions from the audience, please? Madam, you are following in Fernandez Hospital all these protocols?
Yes, sir. What we practice only today, I shared.
Yeah. What about the future of this IUGR babies? How they come up in their life and school education, all this? So many questions for the parents.
Absolutely. We have a publication on the outcome of absent and diastolic flow fetuses, fetuses with AEDF and then doing very well. Initially, the recommendation was to deliver at 34 weeks of pregnancy. Then we realized that because of the intrauterine hypoxia, there is a more chance of cerebral palsy in this particular cohort. Yeah, therefore, we changed absent and diastolic flow to 32 weeks to consider delivery rather than 34 weeks. We do have the publication, sir.
There is a belief that most of them babies will be diabetic or something like that, likely to get diabetes in future. Everybody will be thinking, is it true or something like
Absolutely,
that?
Absolutely, the literature says so, Barker's hypothesis. We don't have that follow-up of, more than 10 years.
Yeah.
The neonatal team is doing a good job. We will get back.
Thank you, madam. Thank you for that.
Congratulations. Congratulations, Dr. Susila, for your excellent talk. And
It's a
we are
dynamic
very
and
happy.
nice presentation, ma'am. I request Dr. Sunita Subramanian ma'am to hand over the memento to Dr. Susila ma'am.
Thank you. Now, may I take the chance? First of all, I thank the organizers for giving me this chance. Sir Bharati Madam, Parasarthi Reddy, to be here on this glorious day. Now, I invite Professor Dr. V. Balaji Garu. He has the MD FRCP, London, and fellowship in diabetology from Sweden. Chairman and Managing Director, Senior Consultant Diabetes, and Honorary Founder Secretary General Diabetes in Pregnancy Study Group here, and Indian Representative IADPSZ, and recipient of the International Diabetic Federation Fellowship Award in 95, received Dr. Jayashree Patel and BC Mehta Original Research Paper Award in 2004, awarded the Orator of Haas Senior Leadership Lectureship in Diabetes in API 2019, awarded the Professor Sam ZP Moses Oration RSSI DI 2010, awarded the prestigious Dr. B.R. Sengupta Oration API 2011, received a Vocational Excellence Award Dr. MGR Medical University 2012, received Dr. C.D. Srinivasan Murthy Golden Oration RSSD 2016 in Karnataka, received the Legend Award from Healthcare Activities 2018, received recipient of the Inspiring Diabetologist of India Award 2018, recipient of the Annual Excellence in Diabetology Award 2019 Economic Times, received Excellence in Diabetology Award 2022 Times of India, has over 200 papers published in national and international journals. Good morning, sir. I welcome you all and we'll be happy to share your knowledge. Thank you.
Good morning, everybody. At the outset, I thank the chairman for the kind introduction, and I also like to thank the Andhra Pradesh Obstetric and Gynecological Society for inviting me for this August meeting. I am the odd man out. I am a clinical diabetologist, not an obstetrician. So my presentation on GDM will be based on the clinical perspective. But I shall talk to you predominantly on screening today, on the DIPSI criteria about screening, whether you want to screen universally, selectively, you want to screen early or late, you want to do repeat screening, why you want to do all that, whether you have any evidence. I am talking to you on evidence-based, Indian evidence-based. So gestational diabetes, already you are aware that defined as any degree of glucose intolerance first recognized during pregnancy. Now it has got different names. It can be called as HIP, it is also called as true GDM. But what you should know, anything maybe type 1, type 2 first recognized during pregnancy, we call it as gestational diabetes. So the concern being it presents beta cell dysfunction. In other words, future diabetes, type 2 diabetes is a high possibility, and it's an evolution in the stage of type 2 diabetes. The concern being it's playing a crucial role in diabetes, in other words, future cardiac risk also. So when we talk about ethnicity, Indian women have 11-fold increase of developing glucose intolerance during pregnancy compared to our Caucasian counterparts. And if you take the ethnic group, South Asian countries, Indian women have the highest frequency of gestational diabetes. So diagnosis is essential in all pregnant women, especially in high ethnic background. So universal screening now has been accepted as a standard procedure. Earlier, the ADA used to recommend selective screening, but ADS for Americans and Indians, we see the ethnicity. We try to go for universal screening. Even the IAD PSG has accepted universal screening. Now, early screening. Now we come to the basic of early screening. Why do you want to screen early? What is the benefit of early screening? This is a slide from Japan, which you see the slide, you will know that 63.6% in the first trimester and the rest in the second trimester itself. So the importance of screening glucose tolerance in the Asians. The implications, why, what happens? See, the GDM, what happens? See, does severe macrosomia manifest early, as early as 11 to 14th weeks of gestation? Yes, severe macrosomia manifests early. How? Why? You see the pathophysiology. Each islet cell functions as an endocrine organ, and the pancreatic cells differentiate in 10th and 11th week itself, and it can recognize and respond to maternal glycemia at 11 to 15th weeks of gestation. The problem is once the beta cell is stimulated inside the uterus, it goes in an autologous fashion. So the best thing is you must make sure when you are treating a gestational diabetes that the fetus does not recognize the mother as diabetes. Once the maternal glucose stimulates the fetal pancreas, then the organogenesis, all those things get affected, big baby, so on and so forth. So this is what happens. Fetus are exposed to increased amniotic fluid glucose before 15 weeks of gestation. That metabolic alterations are underway before diagnosis, and earlier screening and intervention may be warranted. So this is a study which shows that GDM manifests in all pregnancy. When we see about 4,000 and odd women screened, when we divided them into 3 groups, less than 16, and then 17 to 23, and then 24. So you can see here the crux of the slide. This is what I want you to know. 38% of GDM women were diagnosed before the recommended weeks of screening. So again, what happens is the WHO also endorses in a high-risk population, here testing in early trimester is recommended. Another study which we published, again I want to show you here the crux here is, if you see, almost 1/3 of all GDM cases were diagnosed during first trimester itself. So you may be wondering whether the GDM does not matter, whether they are true GDMs, whether GDMs, they may be IFGs or IGTs outside pregnancy. Once they come into the confinement of pregnancy, they all come under the category of GDM. And this is some of the studies abroad which have showed if you screen them early and pick them early, you can avoid complications like hydramnios, preterm deliveries, premature rupture of membranes, and fetal anomalies. So if you ask me, because the threshold for macrosomia is the lowest, so when you treat for macrosomia at 140, automatically the other complications, the threshold is higher, you automatically run through it. And this is the fuel meritoric teratogenesis, where you see the gestational diabetes towards the end, mainly affecting the stomatic growth. This is what the Western people say, and if you see in their slide, this is one of the slides from my friend Moshe Hod. I just want you to concentrate on the last part. If you see in GDM, the major anomalies is more than 3%, statistically significant. It shows that GDM can occur in the first trimester also. So what happens? Why? So this is very, very important. Early metabolic imprinting may affect the fetal growth. So human studies have shown that increase in pancreatic beta cell mass and insulin secretion of the fetus in poorly controlled diabetic by 16th week of gestation. So there is an increase. So the increase is throughout the second trimester until 26 weeks of gestation, and the priming of beta cells in mild gestation may occur for the persistent fetal hyperinsulinemia throughout pregnancy. So the risk of accelerated fetal growth even when the mother enjoys. So what happens here? Good metabolic control later pregnancy. So you pick them late. So you pick them maybe at 20 weeks. But if the beta cell is primed at 15th week, then even you treat them from 20 weeks and then you give them a very good control. Already when the beta cell is primed, you may still get a big baby. So that is why early screening becomes very important. I can show the data on that in subsequent slides. So early maternal metabolic imprinting may affect the fetal growth, which we want to avoid. This is a study which is done in our center. The percentage is very high because it's a referral center where we divided the patients into two groups. If you can see, the group 1 detected 0 to 23 weeks, the group 2 detected beyond 24 weeks of gestation. The same level of care was given to both of them, same HbA1c maintained on both of them. If you see the outcome, the people who were treated late had a birth weight which was much higher compared to people who were picked up and treated early. They are the birth weight same of normal glucose tolerant women. So picking them early, treating them early, so screening them early, picking them early has definitely got advantages. So not only that, so now we have finished universal screening, we're talking about early screening, now repeat screening. So you have somebody in your clinic who's coming, you check them once and you find them normal, so please don't leave them. So based on the merits of the case, family history and other risk factors, you may have to screen them. So repeat testing, when they were screened, repeat screening of these people, we found 28% of these women were detected to have gestational diabetes on repeat testing. So you have to do universal screening, early screening, repeat screening. And now we come to the DIPSI criteria for the diagnosis and guidelines. This is the test which has now been accepted all over by the WHO, FIGO, and the IDF. And this is very simple test where a 2-hour plasma glucose of 140 with 75 gram glucose administered to the pregnant women in the fasting or non-fasting state without regarding to the timing of the last meal will identify people with GDM. So what is the basis of this test? What happens is after a meal, a normal glucose tolerant woman could be able to maintain euglycemia despite glucose challenge because they have adequate insulin response. Whereas a woman with GDM, impaired insulin secretion, a glycemic control increases with the meal, and when you give a glucose, it exaggerates further. So what happens, the single test procedure in the fasting or non-fasting state, irrespective of the last meal timing, is rational as glucose concentration during glucose tolerance test will be affected least the timing since the last meal in a normal person, whereas in a GDM when there's impaired glucose secretion and insulin resistance, it will be impaired. So this walk-in test is recommended by Diabetes and Pregnancy Study Group India. And what about, there's no point talking about a number when you don't have a proof. The proof of a pudding is in the taste and you eat. So when we keep talking about this 140 number, is it we have to get the outcome data to see that this is definitely the number is worthwhile. So this is a study, if you see here, you have the 2 bars, you have the green bars, which is the normal glucose tolerant women, and you have the GDM in the red bars, which are intervened. We have intervened them for a 140 milligram of the DIPSI criteria, and after intervention you see the birth weight distribution was similar between the normal glucose tolerant and GDM women after intervention and was not associated with macrosomia when you treat them for 140. So this cost-effective and evidence-based procedure meets our responsibility, a single-step definitive diagnostic test, especially belonging people when they belong to a lower socio-economic status. So this is again the study where we did our diabetic prevention and awareness project, where we got a national award, where the National Family Health Survey again came back and did their survey. What they found was the small for gestational age was 17% before our study, and then after that when we did our intervention it was reduced by 41.2%. And if you see the large for gestational age, 19% reduced by 63.2% to 7.26%. So this single initiative of achieving birth weight of infants appropriate to gestational age has a significant positive effect. Don't think all these people are given insulin, no. In this community project, 90 to 95% of people were manipulated on diet alone. So only less than 5% required insulin. So a little manipulation, you can able to get a very, very good results. So this is another study by Professor Jitendra Singh earlier, who was with us in DIPSI, now he's a central minister. So he did the study in Jammu and published it in JAPI, where he had the control and he had the GDM he treated, and he had some GDMs who did not want treatment. When he compared all of them, you see the GDM without treatment, the complications are preterm, macrosomia, etc., are extremely high. So this study proves that advantages or adhering to the DIPSI criteria, you are able to get better results. So this is some of the studies abroad which says the same thing, that diagnosis of GDM with 2-hour glucose and treatment in a combined diabetes antenatal clinic is worthwhile, as has decreased macrosomia and fewer emergency cesarean sections. And also treatment of GDM 1 hour, 2-hour, 140 was associated with reduced risk of adverse pregnancy outcomes. So this is again, now all of you are aware of IAD-PSG, which is now the new WHO criteria, and when we compare it with the DIPSI criteria, you have the 3 tests of IAD-PSG, whereas the 1 test of DIPSI, if you see the percentage, it is 14.6 and 13.4%. In our study, it shows the difference was 1.2%, and which was statistically insignificant. So you can, instead of doing 3 tests, you can simply do the 2 tests, and still you're not scientifically wrong, and you're not going to lose any people, and the statistic significant rate is extremely low, and it is not at all significant for you, and you need not be worried that you're missing out on any patients. So the advantages of DIPSI procedure is it requires only 1 blood sample drawn at 2 hours with 75 gram oral load for estimating plasma glucose, and maybe fasting or non-fasting, and even if the test is repeated in each trimester, the cost of the procedure is 66% less compared to IAD-PSG recommended procedure. So DIPSI procedure is feasible, sustainable, and cost effective. So hence, ladies and gentlemen, diagnosis of GDM with 2-hour post-glucose of 140 and treatment is worthwhile with decreased macrosomia, few emergency cesarean, perinatal mortality, and improve women's quality of life. So this is again we study which we did along with Israel to show the cost effectiveness. So this is on 2 different, see the objective was associated, elevated GDM is associated, all that you forget. So what we want here to do is we wanted to know, because Israel is a different setup and Indian is a different setup. So both the tests, if you do treat for GDM, where there any benefit, so the result where you are supposed to see GDM interventions are highly cost effective both in Indian and Israeli settings by the WHO standards. And noting large differences between these countries in GDM, prevalence and cost, GDM intervention is cost effective in diversity. Because earlier there was some talk, why do you want to pick these GDM people early? You can always pick them as 20 to 24 weeks so that you will not lose anybody. So definitely that is from the epidemiological perspective, but from the clinician's perspective, picking them early, treating them early, definitely you have benefits. The Tamil Nadu State Health Society operational guidelines after our study publications, it has made DIPSI publication. This is mandatory screening at 12 to 16 weeks, second screening at 24 to 28 weeks, and third screening at 32 to 34 weeks. And after this, one step, the Ministry of Health and Family Welfare has made screening mandatory to supply glucometers and to use it as a routine procedure. We also had the point of care testing where we compared the glucometer, and the result of this study was the CBG value at a 2-hour plasma glucose level of 140, or a glucometer may be recommended for healthcare people where the lab technology is not feasible. So using glucometers standardized for measuring plasma glucose. So the WHO also endorsed this idea, and it is endorsed in their recommendations in 2013. So these are the WHO observations and recommendations, and what it says is, if you see for a pregnant woman, the request to attend fasting for a blood test may not be realistic because of the long travel to a distance clinic in many parts of the world. So hence a non-fasting test may be the only practical approach. And as 2-step procedure requiring attendance on 2 separate occasions not feasible in many low middle income countries. So a single-step procedure to diagnose GDM is now endorsed by WHO. And also in the strategies to be considered equally effective, the Diabetes and Pregnancy Study Group guidelines is also accepted now by the WHO. And the FIGO, again what the FIGO says is, in the Indian subcontinent, medium to low resource settings serving high population at risk, a 2-hour value of 75 fasting or non-fasting is GDM, and all women to be booked from the first trimester. The FIGO IDF joint statement also endorses the view saying that you can use the WHO, the DIPSI or the old WHO criteria. And this is the technical and operating guidelines from the Maternal Health Division, Ministry of Health and Family Welfare, Government of India, which again I don't want to go into these details, again says the same thing of treatment. So ladies and gentlemen, the India's contribution have made an impact on GDM diagnosis management in FIGO, WHO and the IDF. And let me summarize the whole thing. This is exactly what I have been speaking to you. Ethnically Indian women are prone to develop gestational diabetes. Universal screening is necessary in a high-risk population, especially in the Indian context. Customized screening, community 75-gram glucose challenge irrespective of the last meal timing, that is the DIPSI criteria. GDM diagnosed with a post-glucose load of 140. And if you have all the facilities, single test that is cost-effective and reliable. And in the clinics, if you have all the facility, you can do the conventional methods also. And screening for the glucose intolerance at the earliest opportunity during pregnancy. And repeat screening whenever it's negative. So let me thank once again the organizers for giving me this opportunity, and I also thank for having a patient listening. And if you have any queries or questions, I request the chairman to put forth since I have to leave back to Chennai. So any questions or queries, I will be.
Thank you very much, Dr. Balaji. At the same time, I congratulate you for the extensive study and talk on screening of, not only screening of GDM, you have covered part of GDM also. And I request the audience, if they are having any doubts, interactive session.
Yes, ma'am.
Sir. Sir, what about the take-home message is you start screening as early as 12 weeks.
Ideally what we see, we screen at the first booking itself.
First visit. Okay.
First visit itself. With the first booking for some people may be early, may be late. But at the first opportunity when we see, we advise them, we screen them and we advise everybody. Because of
12 to 16.
Yeah, problem is most of our people are IGTs or IFGs outside pregnancy. The moment they become pregnant, the sugar goes up and they become GDM or so-called GDM, or you can call that as HIP also, hyperglycemia and pregnancy. So earliest booking itself, we have picked up so many people. If they are left for 20 weeks, by the time the beta cell is primed, they get macrosomia.
That means any change in the incidence of anomalies, if we presume that it is at 12 weeks.
Yeah, definitely there will be. We have also done that. We pick them early, treat them early. That is what. One is macrosomia. We were concentrating on macrosomia. So what happens is, if you talk about the Canadian guidelines, you talk about American guidelines or the Australian guidelines, the cutoff values are high. So what happens is the anomalies are higher. If you take the gradient of anomalies when you get macrosomia, when you cut off for macrosomia, it's the lowest, 140. So when you're treating for 140, already the other anomalies do not come because you're already in a lower level. So that is what I mentioned.
What about this thing, HOMA-IR, any light on HOMA-IR and fasting insulin levels? Recently they are coming.
Yeah, that again depends on the testing. We don't do it on regular routine individuals.
Regular individuals I'm talking about, not only pregnant, sir.
Okay.
Triglycerides and sugar ratio.
Yes.
And HOMA-IR and
Yes.
fasting insulin.
HOMA-IR definitely in GDM it will be high because it is a classical insulin resistant state and a beta cell dysfunction followed by insulin resistant state. The HOMA-IR will be high in people with GDM unless you are dealing with type 1.
Is it going to replace HbA1c, sir?
Can, but it's very, if you talk about HbA1c in gestational diabetes, is predominantly you can't use it as a, what do you call, as for control because of the turnover, rapid turnover, and it has to be done very fast. Yes. So it can be only used to find out whether they are pre-gestational diabetes or gestational diabetes with the help of HbA1c. And if you want to do HbA1c in controlling, you should do almost every month because of the rapid turnover. So HbA1c, I would not call it as a very good tool to check the prognosis in a GDM.
Thank you for your explanation. Any questions from the audience, please?
Yes, sir.
Sir, generally you said that we are screening after 75 grams of oral glucose, whatever we are giving. But then many times we find patients only their fasting is high. So how
See-
do we identify these patients?
See, the problem what you're talking, we have also done a study where they compared the fasting and PP, okay? So when we do only the fasting and not do the PP, we are missing almost 76 to 79% of patients.
No,
I
no,
understand
like,
what you're
yeah.
saying. That
We are
is a-
doing both fasting
Yeah,
and
that is what
75
if-
gram.
What is the crux of the problem here is a community-based approach. In a community, I am not saying not to do the fasting. What I am saying is if the patient is not in fasting, please don't send them back. You do whatever the time they come, you do the test till you are right. If the patient is coming in fasting, that's why I said fasting or non-fasting. I never said only non-fasting. So if you have the facility, the patient comes in fasting, please do. But if the patient is not in fasting, please don't send them back. Again, you can give a glucose and do it again.
But then if the fasting hours, like they say, RCOG people say that 8 to 10 hours of fasting is required, and suppose she has eaten late night or early morning something,
All that
then her
we have-
fasting also will come high.
And all that we have tested, all depends on your basic insulin reserve. That paper is published, you can check in Acta Diabetologia, the full paper on this one-step procedure, how it came, because it took 1 year for us to accept that paper. They didn't believe too good to be true. This is also true in case of type 2 diabetes. So what I am saying is all that whatever you say is good if you have a normal insulin response. Whatever you do, your sugar will be normal.
Any other
If you
questions from
have,
the audience?
if you have a non-equivalent response, in other words, your response is suboptimal. So whatever you do, you will not get the normal level in pregnancy or in non-pregnancy.
Sir, shall we go for the next talk? Any other questions?
Good morning, sir. I am Dr. Saroja. I practice in Bhadrachalam. So I usually routinely do HbA1c. In first visit, I do hemoglobin, HbA1c, and thyroid profile, sir. So if the mother is at 6 weeks of pregnancy and her mean plasma glucose level is 300, should I wait for the 12 weeks or 6 months? So I should advise termination.
Immediately see above 300, that shows their pre-gestational diabetes,
Okay.
and a hemoglobin above 6% says clearly they have been pre-gestational diabetes. You should start aggressive treatment. That is the first 6 weeks is where the organogenesis takes place. So you start aggressive treatment, bring the sugars down.
So aggressive treatment, or should I advise her for termination of pregnancy? Because there is
Termination of
evidence-
pregnancy again depends. We have had even 12 when they had a normal delivery. So termination of pregnancy again depends on your fetal surveillance and all the other tests are normal. Whatever you do from the obstetric side to make sure the baby has no anomalies, everything
No,
is
sir.
normal.
My question is,
Ah.
early detection of, I detected at 6 weeks.
Yes.
Her plasma level is 300.
Yes.
So the sugar levels may have affected.
May
the-
have, that's what I'm saying. You do a fetal surveillance.
surveillance.
You do a
Okay.
fetal surveillance, you find everything is normal. It is
Okay.
not
Start
100%.
treatment also.
We can wait.
Yes,
and
you can
see.
wait and see.
See,
If there is
okay.
any abnormality, you have to terminate the pregnancy.
And one more question, sir. If we do at 24 weeks OGTT, so S75, I usually do S75, so there is no. So if it is abnormal, more than 150, I advise the morning fasting glucose and PPBS. So they both are normal. Then advise dietary advice. I give dietary advice to the patient. So should I repeat the test? S75 I should repeat, or I can follow with
No,
fasting.
once you diagnose GTT with GDM, you need not again repeat a GTT.
GTT.
You
Okay.
just give them 2 weeks of medical nutrition therapy and then subsequently do the fasting PP. 90, 120 or above, you have to treat either with diet, beyond that with insulin or OHA medicine.
Thank you, sir.
Thank you very much,
Thank you, sir.
doctor.
Sir, thank you so
Thank you,
much.
sir,
Now I request the
for clarifying
chairpersons
our
to give
audience
the
doubts.
mementos and
Next, may I
certificates.
call the next speaker, Madam.
Request the chairpersons to come and give the memento and certificate. Sir, before moving on to the next session, a small announcement. Before moving on to the next session, small announcement, madam. So, a lot of PGs, they are here sitting in Hall A and Hall B, not moving on to the paper and poster presentations. I request the PGs to go according to your sessions. Already time is allotted and intimated to you. Please go to the halls and present your papers and posters. Thank you. Thank you so much, madam.
I want to introduce Dr. Sailaja Devi, DNB, senior consultant obstetrician at Fernandez Hospital since 2007. She has done high-risk pregnancy and obstetric medical disorders clinic in Fernandez Hospital, Hyderabad, Hydergoda, Hyderabad. Her educational qualification, MBBS, Tirupati SVMC, DNB in OBG, New Delhi in 2007, DGO, NTR University Health Sciences, Vijayawada 2001. This is all her qualification. And regarding teaching and training, she is having academic activities including regular teaching session for postgraduates and overseas observers and professional midwifery educational training, planning the academic roster and setting up of obstetric protocols. She served as faculty for the following workshops conducted by Fernandez Hospital at various places: obstetric emergencies and life support skills, obstetric anal sphincter injury, fetal monitoring, obstetric medicine update, obstetric life support skills by American Academy of Family Physicians conducted by EMRI, and workshops in critical care in obstetrics. In addition to that, I know Dr. Sailaja, who is the neighborer or maybe the opposite house in Tirupati, because she is the student of SVMC Tirupati. So I invite Dr. Sailaja Devi. Induction of labor, current trends.
Thank you, ma'am, for that kind introduction. I'm happy to share that I'm a student of the SVA Medical College. I did my both post-graduation and undergraduation from this institute, later followed by DNB in the Fernandez Hospital. So today's topic given for me is induction of labor. So what are the recent current trends? Coming to the induction of labor, why we need to discuss that one? Since there is an increase in the incidence of induction of the labor, we need to have focus on improving the success rate and enhancing the safety of the procedure. The most important thing that we need to know what is the optimal time for induction of labor and what are the optimal methods of induction of labor. So we all know the definition of the induction of the labor. We should consider induction when the benefits of delivery to either the mother or the fetus outweigh the risk of pregnancy continuation. It's the iatrogenic stimulation of the contractions. What is the overall incidence of induction of the labor? The worldwide it is around 9.6% of deliveries are involved in a labor induction. The incidence is more in Asian and the Latin American countries. At our institutes, the induction rate for the last 10 years is almost hovering between the 35 to 40% is the induction rate with us. The more important is at the start of induction itself, the counseling is more important. We need to spend more time to the couple. What is the indication for induction? What is the outcomes? What is the duration of the inductions? What are the management of the pain relief or the supportive that you are providing in your institute during induction process? What are the alternate options? What is the rate of failed induction? What should be done if there is a failed induction? This is the more important. At the end of the journey of induction of the labor, the mother should be happy about the induction process. Otherwise, they will have a negative experiences with regarding the birth. So counseling at the start of induction is more important. Coming to the optimal method of induction of the labor, optimal timing of induction of the labor. Some most common indications for induction of the labor are prolonged pregnancies, hypertension complicating pregnancy, diabetes complicating pregnancy, and the less common like fetal growth restriction and the small for gestational age babies also. These are the 4 more common causes for induction of the labor. The less common causes like oligohydramnios, advanced maternal age, high BMI are the less common causes for the induction of the labor. Coming to the prolonged pregnancy, should we consider induction at 41 weeks of pregnancy or 42 weeks of pregnancy? The studies have shown that induction, we compared between the 41 weeks versus 42 weeks of pregnancy. Induction at the 41 weeks of pregnancy showed there is a reduced perinatal mortality rate. The number needed to prevent one case of perinatal mortality is around 175, and the rate of NICU admissions and macrosomia is reduced by inducing at 41 weeks. At the same time, there is no difference in the cesarean section rate or assisted vaginal birth or the obstetric anal sphincter injury between the two groups. The uncomplicated singleton, so the opinion of the guideline is to consider induction at 41 weeks for uncomplicated singleton pregnancies. Coming to the chronic hypertension cases, when we should consider induction of labor, if the woman is not under any medication and controlled blood pressures, we consider induction between 38 to 39 weeks of pregnancy. While on medication and the blood pressures are controlled, consider induction between 37 to 39 weeks. Uncontrolled hypertension associated with any fetal growth restriction is there, maybe you need to consider delivery early around 36 to 37 weeks of pregnancy. Coming to the hypertension in the pregnancy, like gestational hypertension, consider delivery at 37 weeks. Preeclampsia without severe features, consider delivery at 37 weeks of pregnancy. Preeclampsia with severe features, we need to consider delivery at 34 weeks of pregnancy. No point in waiting for severe preeclampsia beyond 34 weeks of pregnancy. Waiting for severe preeclampsia with severe features, the chances of morbidity and mortality for the mother and the baby will increase after 34 weeks. So ideal is to consider delivery by 34 weeks of pregnancy. These are the other indications for hypertensive disorders wherein we need to immediately consider delivery, no point in waiting, based on the maternal and the fetal condition. Suppose if the mother is having complications with hypertension like eclampsia, HELP, pulmonary edema, if the urine output is less and an acute kidney injury is there, the creatinine is rising, then we need to consider the immediate delivery for the mother. The next common cause for induction of labor indication is the diabetes complicating pregnancy. Gestational diabetes, only on diet and exercise, that the medical nutritional therapy, you can manage as non-diabetic woman, and you can wait till 41 weeks of pregnancy. Suppose if the woman is medically managed with oral hypoglycemic agents or insulin and they are well controlled, consider induction around 39 weeks of pregnancy. We need to individualize the case based on the poorly controlled or associated any comorbidities or any fetal growth restriction is there. Coming to the pre-gestational diabetes mellitus, well controlled, consider delivery by 39 weeks of pregnancy. If there are associated vascular complications, any superimposed preeclampsia is there, or previous stillbirth, sugars are not well controlled, then you need to consider delivery around 36 or earlier gestational age. Coming to the cholestasis of the pregnancy, intrahepatic cholestasis of pregnancy, we are worried because this condition is associated with the stillbirth. There is no test to accurately predict the increased risk of fetal demise. Earlier cutoff we used to take to diagnose as obstetric cholestasis is total bile acids more than 10 micromoles per liter is the cutoff to diagnose as cholestasis of pregnancy. This is the recent article published in BJOJ June 2022 in which the cutoffs has changed from 10 to 19 micromoles to diagnose an obstetric cholestasis. Based on the bile acid levels, we need to consider the timing of the delivery. Suppose if the bile acids are between 19 to 39, the risk for the baby to have a stillbirth is similar to that of the woman without cholestasis of pregnancy till 40 weeks of pregnancy. So don't cross EDD for this group. If the total bile acids are around 40 to 99, the risk of the baby to have a stillbirth is similar to that of the woman without cholestasis of pregnancy at 38 to 39 weeks. So consider delivery at 38 to 39 weeks. Don't cross after 39 weeks of pregnancy. There is increased risk of stillbirth when the total bile acids are more than 100. So in this situation, like more than 100 bile acids, consider delivery around 35 to 36 weeks of pregnancy. We should remember there are no tests to accurately predict the increased risk of fetal demise in this group. The other common indication we have in our labor ward is the premature rupture of the membrane. So the term cases proceed to deliver, or you can give an option of expectant for 24 hours to wait for whether the woman sets into spontaneous labor pain. Suppose if the PROM is PPROM like between 34 to 36 plus weeks of pregnancy, you can give an option of expectant management or proceed to immediate delivery. So what is the term PROM active versus expectant management? Induction of labor in this group of term PROM cases reduce the time from rupture of membrane to birth. There is decreased maternal infection rate and then increased chances of the neonatal NICU care for the baby, decreases the probability of the neonate infection. At the same time, without increasing the rate of cesarean section or assisted vaginal delivery rate. The induction of the labor group had a positive experience rather than giving expectant management for 24 or more than 24 hours of pregnancy. So at this point, we need to discuss with the mother the options of waiting for 24 hours or immediate induction. Based on the counseling, based on the woman's decision, we can go with the further step. So we already finished the session on the fetal growth restriction. The fetal growth restriction with an estimated fetal weight less than third centile, consider delivery at 37 weeks of pregnancy. If the estimated fetal weight between third to ninth centile, consider delivery around 38 to 39 weeks of pregnancy, because waiting for these mothers for spontaneous onset of labor, there is increased chance of stillbirth. So consider early delivery for fetal growth restriction cases. Coming to the oligohydramnios, there is a dilemma whether we need to consider amniotic fluid index or a single vertical pocket. So oligohydramnios is defined when the amniotic fluid index is less than 5, or if you are taking single vertical pocket, if the single vertical pocket is less than 2 centimeter, then we define it as an oligohydramnios. If we consider AFI, then the chances of induction will increase with indication for the oligohydramnios as an indication increases if we take only AFI as a cutoff. Isolated oligohydramnios with other causes excluding and there is no fetal growth restriction is not an indication for preterm delivery. Isolated oligohydramnios consider delivery between 36 to 37 weeks of pregnancies. Coming to the multifetal gestation, depending upon whether it's complicated or uncomplicated, we need to plan the delivery. Suppose if it's uncomplicated, and then what is the type of multifetal gestation? It's a DCD8 twin, consider around 38 weeks. If MCD8 twins needs an little early delivery. Associated complications like fetal growth restriction is there, we need to plan the delivery early for DCDA around 36 weeks. The MCD8 twins with an isolated fetal growth restriction consider delivery between 30 to 34 weeks of pregnancy. The other less common indications that we face is advanced maternal age more than 35 years, consider delivery on 39 weeks. ART conception considered between 39 to 40 weeks of pregnancy. The body mass index more than 40, there are studies which show that they are at risk of stillbirth, so consider delivery around 39 weeks of pregnancy. There is a recent articles which shows that what is the role for induction of labor in low risk pregnancies before 40 weeks of pregnancy. There are few studies recently which showed that induction in low risk at 39 weeks of pregnancy, that's before 40 weeks of the pregnancy, has a good outcome. This is a systematic review and meta-analysis of the randomized trials. There are almost 16 randomized trials were there included. So they compared between the induction at 39 weeks of pregnancy. The study has found that induction at 39 weeks, there is no reduction in the section or the perinatal morbidity. There is lower incidence of hypertension and then the fewer chances of meconium stained liquor. Based on these studies, there is no need for us to change the policy of recommending a universal policy of induction of labor at 39 weeks. It should be weighed against the actual circumstances of implementation. What is our feasibility? What is the economic impact? So ACOG guideline recommends that, advisory board recommends that when you are considering induction at 39 weeks of pregnancy, you need to counsel the woman and then decision on the preference of the woman, and based on the resource availability, you need to take a decision. These are the absolute, we know what are the absolute contraindications for induction of the labor. If the mother is having a previous any surgery, like any previous cesarean section, previous classical incision or previous uterine rupture, any infections, non-reactive CTG or transverse slice, there is no point in considering induction of labor for these cases. So how do you assess before induction of the labor? You need to see the history, whether any risk factors for failed induction are there. Are there any risk factors that impact the choice of induction? Are there any risk factors for uterine rupture that impact your choice of induction agent? So make sure that your EDD is verified and then see what is the indication, is the indication correct or not, and then see what are the risk factors that impact the choice of induction agent. Coming to the examination part, we need to check whether the membranes are ruptured or not, is the uterus activating, what is the Bishop score. Based on that, you need to choose your induction agent. Coming to the optimal method of induction of the labor, you should select an induction agent. When you are looking at the comparative studies, the studies are compared to see what is the effectiveness of achieving vaginal delivery in next 24 hours. What is the mode of delivery? What are the risk factors? What are the adverse effects? So we should have an induction agent which helps us to have effective delivery within 24 hours of induction, minimize the side effects like tachycystoly, and which decreases the cesarean section rate and increases the vaginal delivery rate. So we should try to get this ideal outcome with all the induction agents that we have. The induction agents are like mechanical or the pharmacological methods of induction. The main important for the pharmacological method of induction is prostaglandins. In the mechanical method, it is the Foley's or the Cook cervical balloon. So these methods are not as routinely used, and there is no limited data about the use of all this pharmacological and mechanical methods for induction of labor. So we'll go through a few studies which helps us to decide what is the best agent that we can use in prostaglandin PGE2 and in the PGE1. There is a study in the Cochrane database which compares the prostaglandin PGE2 vaginal versus placebo or the no treatment. The study has shown that the vaginal PGE2 dose increases the vaginal delivery in 24 hours. The uterine hyperstimulation with fetal heart rate increases the uterine hyperstimulation with fetal heart rate changes, but at the same time it did not affect anything on the cesarean section rates. It increases the likelihood of cervical changes with no increase in assisted vaginal delivery rate. What is the agent? What is should we consider using the prostaglandin gel or it's a sustained release? When you compare between the sustained release PGE2 and intravaginal gel, there is increased rate of vaginal delivery within 24 hours with pessary. It's a 24 hours release pessary. The sustained release avoids the need for repeated vaginal examination, which is more comfortable for the mother. So this is the different preparation of the sustained release and the gel. The sustained release is 10 milligrams dinoproston. It's a timed release formulation. It has to be removed if the mother is in active labor, if the ruptured membranes, or if there is uterine hyperstimulation. The advantage with the sustained release, as soon as you remove, the effect goes off. So if you have any uterine hyperstimulation, is easy to treat at this point. Consider oxytocin after 30 minutes of removal of insert if required. If you are using a dinoproston gel, usually the maximum of 3 doses can be given, repeat at the interval of 6 hours. If you can't use immediately the syntocinon, you can consider using syntocinon to increase the contractions for augmentation of labor only 6 hours after the use of gel. So this is the method of insertion of the propes. Once you insert into the propes is the pessary, that's the sustained release pessary which can give us 24 hours time. So after inserting into the posterior fornix, make sure you keep the pessary horizontal like this so that the fallout rate of the pessary can be minimized. So coming to the prostaglandin E1, what is the advantage of E1 when you compare to the E2? The E1 is inexpensive, stable at room temperature. That's the more advantage with the E1. So how do you compare? What is the route that we should compare? Whether we need to use vaginal PGE1 or oral PGE1? What is the comparison of the E1 with the E2? So when you compare the oral E1 and then compare to the vaginal PGE1 gel, the oral is likely to have a 19% fewer vaginal births within 24 hours, but the reduced rate of uterine hyperstimulation is there, and there is no difference in the cesarean section rate when you compare the PGE1 oral and vaginal preparation. What is the difference in the outcome between the PGE1 oral route compared to PGE2 vaginal route? Oral prostaglandin E1 has fewer cesarean section rate. When you compare oral PGE1 with the Foley's has less side effects. Coming to the vaginal PGE1 and the PGE2, vaginal PGE1 is more likely to have a vaginal birth, and there is no difference in the hyperstimulation and the cesarean section rate between the two. The contraindications for the PGE1, we know hypersensitivity and previous uterine surgeries. So to summarize about the use of PGE1, both oral and vaginal PGE1 are effective. When you compare PGE1 oral with PGE2, oral has less of fewer cesarean section rates. Vaginal PGE1 has more vaginal births. So oxytocin, we can consider oxytocin versus expectant management. There is lower incidence of vaginal delivery not achieved within 24 hours with oxytocin. When you compare with oxytocin with prostaglandin, there is higher incidence of vaginal delivery not achieved within 24 hours. But there is no difference in cesarean section when you compare oxytocin with prostaglandins. So based on the evidence, it reflects in all the guidelines that PG, prostaglandin, is the first line of choice for induction of labor, except for PROM cases wherein oxytocin is the first choice. Moving on to the mechanical methods of induction of the labor. Mechanical methods, its advantage with the mechanical method is the cost is low, the risk of tachysystole is less. So the disadvantage is if it is a low-lying placenta and we can't use, and there is certain amount of discomfort for the mother when you are using the balloon. So when you compare with the balloon versus vaginal PGE2, the balloon is associated with a reduced risk of the side effects like hyperstimulation. So this is the first picture is about the first one is about the Foley's. The important in the Foley's is you should apply a certain amount of traction, then only it will work. This is second image is showing is a Cook cervical balloon, which have the two balloons, which helps us the little bit more effacement. What is the difference between the double versus the single balloon? If you see, there is no significant difference in the cesarean section rate, vaginal delivery date, or the Bishop score improvement between the double balloon versus single balloon. Similar rate of pyrexia and postpartum hemorrhage. But the advantage with the Foley's is it's cheaper and then we have easily available. So what is the use of membrane sweeping? The membrane sweeping versus no treatment versus PGE2 or amniotomy. The membrane sweeping is associated with the more likely for the woman to experience in spontaneous labor pains and less likely to have a formal induction. But there is no difference in the vaginal delivery or C-section or adverse outcomes between the membrane sweep group versus other induction groups. Should we use sequential induction or a concurrent induction? That means, should we use one method followed by the other method, or simultaneously should we use prostaglandin and PGE2? Sequential or concurrent induction comparison, when you compare, if you use concurrent balloon with oxytocin versus sequential, there is increased rate of vaginal birth. Concurrent use of balloon plus prostaglandin or oxytocin versus sequential, there is increased risk of the vaginal birth. So what is the role of outpatient induction of labor? Mechanical methods can be considered for outpatient induction of labor. There is limited data. Outpatient is cost effective, but it is not universally practiced. It's very difficult to monitor the mother. Only in the high resource setting, in few places, only for the trials, the few cases of outpatient inductions were done. So looking at the evidence, what are the induction modes, that methods of induction we have, we will look into the few guidelines what we usually use. So WHO guideline recommends oral PGE1 25 micrograms second hourly or vaginal PGE1 25 micrograms sixth hourly. If you see the Indian guideline, there is PGE1 is not approved for us. It's only the PGE2 that we can consider for induction of labor. If there is a previous cesarean section, then we can consider using the Foley's catheter. The NICE guideline does not recommend PGE1 for induction of labor. Only in cases of IUFD, the PGE1 is recommended. They consider only PGE2 as a mode of induction agent. When you look at the American College guidelines, it says they consider PGE1 and PGE2 for induction of labor. So coming to the practice points of the induction agent, the first line induction agents that we are available is PGE2 and then E1. And then we should balance the risk of hyperstimulation. The different preparations of PG2 are equally effective. More important is monitoring in induction. We should assess the maternal fetal condition, uterine activity and the Bishop score. How do you assess? When do you go for the second method of induction of agent? With the PGE2, assess after 6 hours. With the inserts or mechanical method, assess after 12 to 24 hours. How to select the second method? It depends upon the uterine activity and whether the cervical changes. If the cervix is closed with uterine activity, consider balloon. If the cervical changes are there but no uterine activity, consider using PGE2 gel. So we know the complications of induction of labor, the tachysystole, failed induction, cord prolapse, uterine rupture. We expect at least 5 contractions in 10 minutes will be sufficient for us for the normal progress of labor. If the contractions are more than 5 in 10 minutes period, it's called as a tachysystole. This is the CTG which showing tachysystole, which shows too many contractions here associated that CTG changes are available. We should consider tocolysis. Then now at present the tocolytic agent of choice that is available in the market is only nitroglycerin. We don't have nitroglycerin spray. We don't have terbutaline available in the market. So we should have, how do you predict the success of induction of labor? The factors affecting prediction are the maternal factors and the fetal factors. The maternal factors like Bishop score, parity, BMI, age. In the fetal factors, we should consider the gestational age at induction and estimated fetal weight. What is the incidence of induction of failed induction? It's around 15 to 20% is the overall failed induction rate. There is universal standards exist for what constitutes a failed induction. How do you diagnose a failed induction? When the women who do not achieve regular contractions and cervical changes at least 24 hours of oxytocin stimulation with artificial rupture of membrane, then you label it as a failed induction, then go for a cesarean section. In term PROM, the induction agents like induction of labor can be done with PGE or oxytocin are equally effective, but PGE2 associated with more higher risk of chorioamnionitis. The more important and challenging is previous cesarean section cases and induction of the labor. They are associated with higher rate of uterine rupture. If the cervix is favorable, you can consider artificial rupture of membrane and oxytocin. If in unfavorable cervix is a cervical ripening agent, you can consider. The balloon induction is safe. It can be considered for previous cesarean section rates. What is the role of prostaglandin in the case of previous cesarean section rate? All the guidelines advise, few guidelines does not advise use of prostaglandin with the previous cesarean section. NICE guidelines concludes the cautious use of PGE2. Coming to the twins, the options that we have for induction of the labor for the twins is only the balloon catheters and oxytocin. The prostaglandins, the data is limited. The more challenging for us is the induction of labor in stillbirths, in intrauterine fetal death. Induction for termination of the pregnancy is ITOP. So when the live birth is not anticipated, that is fetal death has already occurred, during the induction process you are expecting the fetal death or you are expecting the natural death once the infant is born, then it's called as induction for termination of the pregnancy, ITOP. We can consider using mifepristone for ITOP because mifepristone is the progesterone receptor modulator. It induces the prostaglandin sensitization in the uterus. Before considering PGE as an induction agent, use of mifepristone helps to reduce the time of expulsion. It can be decreased by mean of 2 to 10 hours. So for ITOP, when you are using prostaglandin, if the time permits, give mifepristone as a priming agent at least 24 to 48 hours before. One dose mifepristone 200 milligrams per oral. Coming to the misoprostol for induction of termination of the pregnancies, PGE1 vaginal is as effective as EG-E2. The advantage with E1 is less costly and no need for any refrigeration. So we can consider most of the time using misoprostol for ITOP. So this is the good article by FIGO about what are the doses that misoprostol recommended regimes, what are the doses based on the gestational age of pregnancy that you can consider. The early gestational age, you can start with the 200 mcg and you enter into the 18 to 26 weeks, go for the 100 mcg. Beyond 26 weeks, the chances of the more contractions can be there, so we can't monitor the fetus here. We can miss the uterine rupture. At this point, maybe you can consider using the less dose like 25 to 50 mcg and then increase the doses every 4th hourly. More challenging is the scarred uterus, previous cesarean section, and you have an intrauterine fetal death. It's very challenging to take care of the mother. We need to balance the risk of repeat cesarean section versus the risk of uterine rupture during induction process. These cases you can consider use of mifepristone 200 milligrams per oral. The other induction agent that you can consider in the third trimester is the mechanical dilator. We can't consider scarred uterus and ITOP term. PGE1 is not advisable. Suppose if it's less than 28 to 30 weeks, you have a scarred uterus and you need to consider ITOP, then you can consider maybe the lower doses of PGE1, but not in the term cases. To conclude, we need to consider optimal timing of induction based on the risk factors when we should deliver, induce when the benefits outweigh the risk. And when you are choosing the agent of choice, so you consider the combination of the methods, may be concurrent, may be difficult. You can use a sequential method of induction, Foley's followed by the PGE. More important is careful monitoring and you need to give an adequate time for the progress of labor to happen. Thank you for the patient hearing.
Dr. Shailja, thanks for your elaborative and extensive lecture on section of labor. And any doubts from the audience? Any questions? We thank you, ma.
Thank you, sir.
Thank you, Shailja. Next, here is a small change in the program. Sorry for the inconvenience. Dr. Priyanka Roy is yet to come. Sir has come?
So small memento and certificate presentation to the madam.
Sorry for the inconvenience. There is small change in this stop. Priyank Roy yet to arrive from the darshan. While we'll have a lecture by Dr. S. Samartharam, the director and head of the Department of Obstetrics and Gynecology, Jaram Hospital, Palakkad, Kerala. Really, he doesn't need any introduction. Still, the awards what he had is winner of the prestigious senior category, Foxy Brian Award, 3 times winner of Dr. C.S. Don Prize, and Foxy Figo Award, AFZ Gold Medal for SRPPH suction cannula, oral hydration therapy to prevent eclampsia and bring down MMR and significant 5 districts of AP. Publications are published by 25 original papers in national and international journals. Special interest is PPH, preeclampsia and amniotic fluid. Optical density, guided induction of labor. And he is famous for his PPH cannula. I welcome you, sir.
Thank you very much.
His talk will be on programming of labor.
Yes. Thank you very much for a nice introduction. Good morning. Good morning, chairpersons, and good morning, everybody. Very much thankful to the organizers for giving me this opportunity. The title of the topic I'm presenting, Programming of Every Labor Guided by Pore Water Floating Vernix Densities, Exploring the Possibilities. Today I'll be giving a fascinating scientific information about spontaneous labor. Greetings from God's own country, Kerala. Obstetrics is a tricky subject with full of dilemmas and uncertainties. For many problems that we face in day-to-day practice, we don't have answers. Here, I would like to share some of such scenarios. Dilemma 1. On the first day of antenatal booking, a woman was given expected date of delivery. The woman and the obstetrician were waiting for that date, but this woman developed labor pains at 35 weeks itself and delivered normally. Birth weight was 2.3 kg. But this baby was fully functionally mature and did not develop respiratory distress. This is the baby. On the other hand, other woman, 4 cesarean pregnancy, unexpected date of delivery, elective C-section was done, birth weight was 3.3 kg, but this baby was functionally premature and developed severe arteries requiring ventilator support. And this is the baby. We don't know why this first baby was fully functionally mature at 35 weeks. Also, we don't know why the second baby was functionally premature, even at 40 weeks, even with birth weight 3.3. ECD twin pregnancies at 31 weeks, delivered by cesarean section. Both the babies had 1.54 kg birth weight, but one baby was functionally premature, another baby was functionally mature. These are the babies.
A40 value 0.23, B is having mild RTS.
This baby is a functionally mature baby.
Twin B, A40 value is 1.55, baby is RTS.
Apgar at 1 minute was 9:10. Dylemo 3. Induction of labor was done and expected date of delivery with cerviprime gel. No uterine action. Gel was repeated once, twice, thrice. No uterine action. Labor has no progress in labor. C-section was done. Another woman, labor induction was done on same expected date of delivery with cerviprime gel. But this woman responded with hyperstimulation, severe fetal bradycardia, emergency C-section was done, low Apgar score. Later, the baby developed cerebral palsy. We don't know why this first woman did not respond well for induction of labor at 40 weeks. Also, we do not know why this woman responded with hyperstimulation for the same dose of prostaglandin at 40 weeks gestation. Definition for term pregnancy. There's so many definitions are there: late preterm, early preterm, and preterm, term, the new term, post-term and all. We don't know the reason why the difficulty in defining the gestational age for term pregnancy. ACOG, RCOG guidelines on antenatal steroids. The cutoff gestational age for antenatal steroids starts from 34 weeks and slowly it went on increasing and reached the current guideline as 38 completed weeks of gestation. We don't know the reason why these recommendations are being changed very frequently. Let us see whether my scientific presentation today can answer these dilemmas. Why obstetricians regularly doing ARM and observing the color and turbidity of amniotic fluid? Sometimes the liquor is watery, milky, buttermilk-like or curdy-like, but we don't know that this color and turbidity of amniotic fluid is having correlation with the fetal functional maturity and onset of spontaneous labor. This is our published article titled Amniotic Fluid Optical Density and its Correlation with the Fetal Functional Maturity and Onset of Spontaneous Labor. This paper was awarded Dr. C.S. Don Prize at AICOG, Varanasi. The basic information from the study is prematurity is associated with less turbid water liquor. Optimally mature babies are associated with milky, buttermilk-like liquor. Post-maturity and sometimes dysmaturity is associated with curdy liquor. Brief account of the study. Observation study involving 360 uncomplicated singleton pregnant women who underwent first trimester scan for CRL gestational age estimation and who were on spontaneous labor. Amniotic fluid samples were collected while doing amniotomy and while doing cesarean section. The color and turbidity of fresh, uncentrifuged amniotic fluid samples were measured in terms of optical density at 650 nanometers wavelength with a simple laboratory colorimeter. The cost of the colorimeter is only just 10,000 rupees. This is what we call as amniotic fluid optical density, that is A4D. Coming to the results, 360 spontaneous labors were spread widely from 35 weeks to 41 weeks. The mean gestational age at onset of spontaneous labor was found to be 38 weeks 3 days plus or minus 7 days. This is our gestational age at delivery. 82% of the babies are delivered at this gestational age. 82% of the deliveries, maximum number of deliveries, occur between 37 weeks to 40 weeks, and 11% of the deliveries occur after 40 weeks, and less than 7% of the babies deliver less than 37 weeks. Only 3.38% of babies only occur on 280th day as per the Neglis rule. The mean A4D at onset of spontaneous labor was found to be 0.98 plus or minus 27. At this A4D value, all the babies were fully functionally mature and none of them developed respiratory distress. But this A4D 0.98 and completion of fetal functional maturity and onset of spontaneous labor, which all go together, occurred at any time from 35 weeks to 42 weeks. In other words, babies can attain completion of functional maturity and go in for spontaneous labor at any time from 35 weeks to 42 weeks. There are early maturers, there are late maturers. This is what we call as indicating individual term for each fetus. Here, I would like to show a batch of babies delivered at different gestational ages, but their optical densities were around 0.9. If you observe the AF samples in these test tubes, these samples are milky, buttermilk-like, or curd-like. I would like to play the small video clippings and I would like you to observe the Apgar scores of each baby. This baby delivered at 35 5 weeks, 36 weeks, 36 weeks, 37 weeks, 38 weeks, 39 weeks, 40 weeks, 41 weeks, 42 weeks. What I would like to impress on you here is, if the A4D value is 0.98, babies are fully functionally mature and do not develop RTS irrespective of the gestational age and birth weight. This baby is 35 weeks, is early maturer. This is a 42 weeks, is a late maturer. And they have different gestational ages and different birth weights. On the other hand, babies born with A4D less than 0.40 were functionally premature and develop varying degrees of respiratory distress irrespective of the gestational age and birth weight. Here, I would like to show another batch of babies delivered at different gestational ages, but their optical densities were less than 0.40. If you observe the AF samples in these test tubes, these are watery. And I would like to play these video clippings.
Baby of Manju, peer
37 weeks, 38 weeks, 38 weeks, 39 weeks, 40 weeks. What I would like to impress on you here is, if the A4D value is less than 0.40, babies are functionally premature and develop varying degrees of RDS irrespective of the gestational age and birth weight. To sum up these observations, a baby can be fully functionally mature even at 35 weeks if the A4D value is 0.98. And the babies are functionally premature even at 40 weeks if the A4D value is less than 0.40. If you observe this graph, the red rings represent functionally mature babies delivered at different gestational ages, but their optical densities are around 0.98. These blue rings represent functionally premature babies delivered at different gestational ages, but their optical densities were less than 0.40. If you draw a cross section at any gestational age like 270 days, you can see all scenarios of functional maturity. This area you can see optimally mature babies. This area is functionally premature babies. This area you can see post-mature and dismature babies. In terms of functional maturity and postnatal survival, a baby at 35 weeks is as good as a baby at 40 weeks. This baby is 35 weeks, this is a 40 weeks baby. Both of them do well postnatally. When we observe the skin surface of functionally mature babies, the skin was mature, pale brown in color with practically no vernix caseosa adherent on these babies. These are mature babies, no vernix caseosa is there on the skin surface. On the other hand, in functionally premature babies, the skin was premature, shiny red in color with plenty of vernix caseosa adherent on their skin surface. When these functionally premature babies become functionally mature in due course of time, this vernix caseosa get detached and get mixed with the amniotic fluid. You can see the vernix clumps floating in the amniotic fluid like this. The color and turbidity of amniotic fluid is due to the shedding of vernix from fetal skin surface in the amniotic fluid. This vernix shedding and color change in liquor starts about 8 to 10 days before the onset of spontaneous labor. This is another paper again published by me, concept of individual term for each fetus from surgeon amniotic fluid optical density. We found there is a surge-like rise in amniotic fluid optical density which coincides with onset of spontaneous labor. There is a slow and prolonged rise in A4D till a value of 0.40 is reached. After this value is attained, the A4D rises like a surge which coincides with the onset of spontaneous labor. Different authors reported surge-like rise in many biologically active substances which participate in the process of spontaneous labor. There is surge in hyaluronic acid, surge in amniotic fluid lecithin, surge in LS ratio, and many authors, animal studies also reported surge in relaxin, oxytocin, fetal cortisol, and so on and so on. Narendran V. et al. Reported lung-skin interaction. Surge-like raising amniotic fluid lecithin induces vernix detachment from fetal skin surface which will get mixed with the amniotic fluid, resulting in surge-like rise in amniotic fluid optical density which coincides with the onset of labor. The surge in amniotic fluid optical density, which coincides with the onset of labor, the duration of surge was found to be 8 to 10 days. Majuk Chile et al. Reported human amniotic fluid cells can produce pro-labor cytokines like IL-6, IL-8, IL-1 beta, and EGF. The exact mechanism of onset of spontaneous labor, which results due to the pro-labor cytokine-rich vernix detachment into amniotic fluid, has to be further explored. Can you give me some water, ma'am? The concept of individual term for each fetus is having a major impact in clinical obstetrics. An early maturing baby, which attains completion of maturity at 35 weeks itself, and for some reason if the labor do not start, by 38 weeks, this baby becomes post-mature, dismature, and sometimes IUFD can take place. On the other hand, a delayed maturer who is destined to mature by 42 weeks, if delivered at 40 weeks, this baby is functionally premature and develop RDS, which may require ventilator support. If labor induction is done on a woman with not ready parturient system, labor do not start well. And these women require multiple dose of prostaglandins, and they land up with prolonged labor, induction failure, cesarean section, and atonic PPH. In what way this post-maturity, dismaturity, and IUFD can be prevented? By delivering the babies at optimal maturity, that is 0.98 plus or minus 27 optical density, it is possible to prevent prematurity, post-maturity, and IUFD. If the AF40 values are around 0.98, babies are optimally mature. Then the question is how to pick up women at AF40 0.98. To avoid invasive amniocentesis and AF40 estimation, we came out with the 4-water scanning by transvaginal sonography. To see this picture here, you can see the vernix clumps floating freely in the amniotic fluid. See here, this is a grade 3 vernix floated density by transvaginal sonography. You can see the vernix clumps floating in the amniotic fluid on 4-water when we do cesarean section. You can compare the vernix clumps floating pattern here. We have divided these vernix floated densities into 3 grades. This is a published article in an international journal. Grade 1.
Grade 1 4-water scan your picture. Hypoechoic 4-water with very few or no echogenic vernix floaters. AF40 less than 0.45. Induction should not be done.
If the picture is like this in 4-water, no echogenic floaters are there, and the woman is not ready, we should not induce labor. This is simply by doing one 4-water scanning, you can pick up this. This is a very important thing.
Grade 2 4-water sonographic video picture. 4-water with moderate echogenic vernix floaters. AF40 value between 0.45 and 0.85. Induction of labor should be deferred. Sometimes we may give antenatal steroids.
If this picture we see in 4-water, it is neither mature nor premature, it is in between. We have to defer induction, and we have to, after 5 days, you may repeat the 4-water scanning. If the grade 3 maturity is there, you can induce. Or if there is a need or an emergency, you can give a course of antenatal steroid. What we found out is by giving antenatal steroid, optical density improves.
Grade 3 4-water sonographic video pictures. 4-water with heavy echogenic floaters. Irregular shaped cloud-like big vernix floaters. Swarming fish-like movement of vernix clumps. If this picture is there, the woman is ready for induction. AF40 value more than 0.86.
This picture is a grade 3 picture, very conspicuous. If you go on doing, you can learn it, it's not a serious problem. Once this picture is there, if the woman is ready for induction, you can trigger labor. The way I do programming of every labor, I would like to share this particular information with you. This is the way how I trigger labor in every woman. And this, we do 4-water scanning by TV sonography around 38 weeks. If grade 1 sonography picture is there, no induction. Review scan after 10 days. If grade 2 sonography picture is there, defer induction, review scan after 4 to 5 days. A course of antenatal steroid may be given. If grade 3 sonography picture is seen, we admit the patient woman on the same evening. We don't do anything during that night. Next morning at 6 a.m., we trigger labor by inserting 22F Foley catheter through cervix. The bulb should be inflated. The bulb should be above the level of internal os. Bulb should be inflated with 70 ml of distilled water. Also, we insert tablet misoprostol 25 or 50 micrograms vaginally. By 11 to 12 a.m., it's just 4 to 5 hours. You can, when you do PV, the bulb is out and it is felt in the vagina. You can remove the bulb, and we can do it by the, because 70 ml of distilled water is inflated. By the time the bulb comes out, it produces a dilatation of 4 to 5 centimeters, and we can do ARM and exclude meconium stain liquor. And further management depends on obstetric findings. This guided induction fails only when there is a malpresentation in positions or unfavorable cervix with cicatrization. Otherwise, induction failures are almost zero. Advantages. You can conduct labor at convenient hour, avoiding deliveries during night time. This will be most interesting for all of you. We can conduct labor at a convenient hour, avoiding deliveries during night time. Helps to monitor labor from 0 hour, that is from the very beginning of labor. This helps to pick up the fetus that develops distress and die at the onset of labor. Very significant reduction in duration of labor process itself. That's about 2 hours. What we have observed here, the labor process itself is come down by 2 hours. Fetal monitoring time is also reduced. Labor is less painful. The woman feels significant pains only while crowning and at the time of delivery of the head. We can give saddle block anesthesia at 8 to 10 centimeter dilatation, and we can avoid long hours of epidural labor analgesia. This technique can also be used to bring down MMR in difficult terrain areas like Assam. We can shift the woman to a well-equipped obstetric unit few hours before triggering labor. We can conduct a safe delivery and prevent maternal deaths. Another most important observation what we have made while doing TV sonography or 4-water scanning, you could see the cord presentation. This cord presentation is very important. All these mothers, when we did ARM, cord prolapse has come. By picking up this woman cord presentation before induction of every labor, we can avoid cord prolapse, which is a devastating complication. In conclusion, 4-water scanning is of every woman at around 28 weeks of gestation helps to assess the woman for preparedness for labor and also helps to detect the cord presentation. This makes obstetrics safe, comfortable for both the mother and obstetrician. Thank you very much.
Thank you very much, Doctor. It is very much thought-provoking, interesting talk, as well as the pictures are very nice, and everybody got impressed with your talk. You deserve for awards and rewards also. Thank you very much.
Thank you, sir. Samadharam doesn't need any introduction, and it is very innovative and interesting lecture. Any questions from the audience, please? Yeah, Radha madam wants to ask question.
It is pleasure to answer questions here.
Yeah, back in when I was doing post-graduation in 82-85, there was an instrument, amnioscope. So it's just like a proctoscope with an obturator. we introduced into the vagina because there are no ultrasonography to assess the dates, past dates, or whether it is premature, especially for induction, as you said. And we put amnioscope and look at the cervix and membranes. There are vernix flakes. It's an added assurance that it is mature. So later on, with the advent of ultrasound, and also the problem is the cervix should be dilated. Otherwise, we cannot visualize the membranes. Os is closed, unfavorable cervix, can't visualize the cervix. So it has gone into, it was obsolete, so we didn't stop using amnioscope. So again, after 37 years, we are almost introducing similar technique. And what is the clinical application in decision making? Suppose it's 35 weeks and there is a definite indication for induction. Suppose if the optical density is less, are we supposed to not to induce? And are we adding another dilemma to the decision making? So these are the doubts.
Yes, thank you very much for a nice question to you. There's one author by George and Japkar. He has done the similar work, but not amniotic fluid optical density. As you said, he did same work. He did same work by amnioscopy. Studies are there, but he found out most of the information what I given to you here. But he was not able to. He could not do study on the density of amniotic fluid. He has not done. But studies are there. But we have a definite marker now that we can, at a particular density, baby is mature, or a particular vernix floated density in the amniotic fluid, baby is mature like that. Your question is 35 weeks. If 35 weeks also there, I boldly, definitely terminate pregnancy. There's no doubt about it. If the optical density is 0.9, it's 100% sure baby is mature. If you leave those babies 35 weeks, by 38 weeks itself, this baby will become post-mature, dismature, and sometimes IUD will take place. I've been doing this work. This is not one day work. More than a quarter century I have taken. In fact, the amount of time I spent on cannula is only 3 months. Whereas this, because I can't take samples just like that, because they're human beings. So it took lots and lots of time. By 2003, this research was over for a clinical utility, and we are doing. And previously we used to take sample and assess. Now we are doing transvaginal sonography, avoiding amniocentesis, and we are doing this. It is 100% correct. There's no.
Okay.
I mean, I'm ready to conduct a labor workshop, induction labor workshop anywhere.
Okay.
Actually, I'm interested. If anybody invite, no. I will select the patient, 10 patients. 10 patients I will induce labor. All of them, the bulb will be expelled by 11:30. And your waiting time, your tension is out. And your fetal monitoring time is also out. And patient, another most important for this is, especially private practitioners. If you take the patient for C-section, he will say, you have done an unnecessary cesarean section. Instead of that, you trigger labor, wait for 5-6 hours, and she may go for section because malpresentation, so many things are there. Then they cannot charge you have done an unnecessary cesarean. This is most important thing. In government hospital, medical college, nobody bothers to whatever the number of C-sections.
Thank you, sir, for your elaborative lecture. And so you cannot conclude by your study that one optical density is a term feeder.
Pardon, please?
At what optical density we can say that it is term feeder?
0.98 if you can take the sample. If you are avoiding taking sample, the grade 3 density of vernix floaters.
But some of the fetus even at 40 weeks also you were telling that they cannot
You have to wait 41 weeks, nothing will happen. It is a delayed maturer. Is a baby destined to mature at 42 weeks, you are taking the baby at 40 weeks. That means functionally premature and developing audience. If suppose you have taken, otherwise you have taken a sample, optical density around 40, less than 0.40, or you have taken a TV scan, it is grade 1. Then what you have to do, don't do anything. Give a dose of steroids, repeat the scan after 5 days.
Okay. Thank you, sir.
And in fact, I tell you, I have to wait for the maturity fetus up to 43 weeks. One baby matured at 43 weeks.
That's what I am worried of this. 43 weeks you are not getting a well-matured baby.
Pardon?
But anyhow, it's a good study, sir. I congratulate you and I wish you all the best.
Thank you.
Thank you. Sir, here is a question from the audience.
Sir, good morning, sir. Sir,
Where are you?
Good morning, sir. Sir, if she is in already in labor but APOD is less than 4, what should we do? We should stop the labor by giving tocolytics or?
I'll tell you one thing. If the optical density is low and she is on labor, she will respond very well for tocolysis. She will respond very well for tocolysis. If the optical density is mature, whatever you do, it will not stop, it will mature.
Thank you, sir. And you are telling about the 75 ml of Foley's catheter.
Yes.
But original
30 ml you give.
usually 30 to 50 ml only it will go through.
But what I suggest, no, why I selected 70 ml, no. But if the 70 ml bulb comes out, no, it is already 6 centimeter dilatation. By morning 6 a.m. to 11 a.m., 11:30 a.m., you will
But
achieve
usual
6.
Foley's catheter cannot withstand
Thank
with,
you.
75 ml, no?
No, I tell you, you have to 22F Foley catheter, I said.
Okay. Thank you. Thank
That's
you.
available in the market.
Thank you, sir.
Not cause any pain or discomfort to the with 70 ml
Pardon?
distension.
Pardon?
70 ml of distending the folic
Nothing,
acid.
no pain, nothing. It won't be anything, no difference between the 30 ml or 70 ml.
Okay.
Thank you, sir.
Can't
Sir,
we
I-
give the Servipran gel, sir?
Huh?
Can't we use
We are not using cervical gem, mesopressor we are using. Mesopressor, 25 or 50. Usually I use 50.
Thank you, sir.
Sir, my doubt is like, sir,
Yeah, here is a question, sir. Yes, ma'am.
sir,
Okay.
my doubt is like, what about amniotic fluid density if it is more than 9, around 35 weeks? You said you have to screen around 38 weeks. Then if the baby is continued to 38 weeks, there is the risk of IUD. So are there any other parameters that we have to screen that fetus with transvaginal sonography that makes us trigger to do at that time?
No, it is not like that. It's only maturity we are testing. No, 35 weeks it is not mature, wait 37 weeks.
No, sir, if it is already matured at 35 weeks, how would we know if you do at 38 weeks? Because by that time it may land in IUD, no, sir?
No, if you see 35 weeks baby is mature, deliver. Why do you want 38 weeks?
If it is mature, if it doesn't go into spontaneous, then...
It should go normally, but sometimes it will not go.
Yeah, in that
Because
case...
biology is different, it will not behave whatever you say. Sometimes, that's why you have gestation stages different and they go for normal deliveries.
In that case, there
Otherwise
is
you
risk
should
of...
not have post-maturity, dismaturity at all, no?
Yes, sir.
Thank you, sir.
Okay.
Right. Indication is itself the maturity. No, I am telling you, that is what I said, individual term for each fetus. A baby will mature at 35 weeks, other baby will mature at 42, 43
No,
weeks.
in every patient, then what is the indication to do optic density test at 35 weeks?
I am
There's no
telling you, you are
indication.
all the time, you are putting your mind at 40 weeks or 39, that's not correct.
So we have to change all the guidelines
Sure,
to deliver at
very
35
sure,
weeks?
it is a path-breaking research.
Suppose there are other indications like preeclampsia or
That
something,
you-
and suppose there is optic density is less.
Ah.
Suppose and we are based on optic density and there is a guideline that is optic density should be based, then we will legally implicate it also. Suppose we
No, I am
indicate,
telling you, you are aware that the baby is premature and you should get ready how to manage the premature baby after delivery.
Sir, you come with certain guidelines, still it is in the research process.
Pardon?
Thank you for your nice lecture, and I think it is time up. Organizers are asking
I
us.
know a lot of questions will there, I will answer
Thank
once
you,
I
sir.
come down.
Lunchtime.
Right.
Now I request our chairpersons, Dr. Sunita Madam and Dr. Manikrao sir, to present memento to Dr. Samudram sir. Now I request Dr. Radha Madam, Vice President, APOGS, to present mementos to Manikrao sir and Sunita ma'am. Now we'll move on to the session 2 of day 1. The theme is the same, this with the obstetric protocols. Now I welcome Dr. Kartiki ma'am onto the stage, chairperson for this session. Madam is the professor and HOD, Department of OBG, Shantiram Medical College, Nandyal. Madam has done her MBBS from Rangaraya Medical College and her MD from Davangiri. I welcome ma'am onto the stage. Our second chairperson for this session is Dr. Nirmala Devi Madam, Associate Professor, Department of OBG, SVMC Tirupati. Madam has done her MBBS at Kurnool Medical College and her MS also from Kurnool Medical College. Madam's fields of interest are family planning and high-risk pregnancy. And Madam has also been awarded the Best Doctor Award for the year 2022 by Government of AP. I welcome ma'am onto the stage. Our third chairperson for this session is Dr. V. Lakshminarayanamma Madam, Associate Professor, Department of OBG, SVMC Tirupati. Madam has done her MBBS and her MD from SVMC Tirupati. Welcome onto the stage, ma'am. Now I request the chairpersons to start this session. Thank you, ma'am. One small adjustment because Dr. Priyanku Rai and Dr. Indranil Datta are on the way, Sir is on the way. So we made small adjustment. Dr. Susila Madam is going to present now. Now I would like to invite Dr. Susila Madam and Chairperson Dr. Lakshminarayanamma Madam is going to introduce. Thank you.
I would like to invite Dr. Susila Pindamnayan Madam. Madam is a consultant obstetrician and gynecologist and Lata Super Specialty Hospital, Vijayawada and Samata Multi Specialty Hospital, Mangalagiri. And President of Obstetrics and Gynecology Society 2022-23. And Madam is a member of MTP Committee FOXY, Organizing Secretary for first APCOG 2015. And Madam also trainer for many of the certificate courses. And also Madam is speaker in international and national conferences. And Madam also author of chapter in FOXY Focus on Aging Gracefully. And Madam is also eco-friendly. So Madam has awarded her first prize in the best photography of indoor and outdoor plants conducted by the FOXY on World Environmental Day celebration 2022. Welcome, Madam.
Thank you, Madam, for the kind introduction. Topic given to me is standard treatment management of hypertensive disorders in pregnancy. I've taken the guidelines, NICE guidelines, ACOG, and especially our FOXY HDP gestosis guidelines, and from up to date. And in the next 15 minutes, which the time is allotted, I'll try to include all the important points to be covered. So, 28-year-old primey, 32 weeks of gestation, with regular antenatal checkups and with no comorbidities, has come to the OPD and her blood pressure was 145/95 and both the readings were so, and no other complaint she has given, and the urine protein was nil. So now we make the diagnosis of gestational hypertension, and the investigations which are to be done are the blood investigations, that is complete blood picture with LFT and RFT. They were normal, and she has been started on tablet labetalol 100 milligrams BD to achieve the target blood pressure of 135/85, and the fetus is assessed by the ultrasound, and the appropriate growth was there. So apart from labetalol, we can also start nifedipine SR, that is a sustained release, and we can go from 20 milligrams to 60 milligrams once daily, can be increased 7 to 14 days, or methyl dopa 250 milligrams 2 to 3 times. But the best option would be labetalol 100 milligrams BD. We can increase by every 2 to 3 days to maximum of 2,400. So my plan was not to admit her because it is not a severe hypertension, and explain her the warning symptoms of headache, abdominal pain, epigastric pain, and blurring of vision, etc. And then I've explained her, I've sent her, and I asked her to come twice weekly for her BP recordings and urine protein. And I wanted to do blood parameters every week and ultrasound assessment 2 to 4 weeks and CTG if indicated. So she came for the review at 32 plus 3 weeks, that is every 3 days she has come. Her BP monitoring was done, it was 130/80. The urine protein was nil, blood parameters which were done weekly were within normal limits, and ultrasound showed appropriate growth and the Dopplers were normal. So I was planning to deliver it at a term because everything was normal, and the postnatal also I wanted to check for her BP twice weekly and continue or reduce the antihypertensives, that is titration of the antihypertensives up till 6 to 8 weeks I wanted to monitor her. This was planned, but at 36 weeks the patient again, she lost the follow-up. In between, she came at 36 weeks. Her blood pressure was 165/115. There were no complaints. The fetal assessment by symphysiospondylite and fetal heart rate by auscultation was normal. She was admitted, and even before starting the line, because it is a gestational hypertension, 200 milligrams stat of labetalol was given, and the blood pressure was stabilized. Blood investigations and dipstick was done. There was no protein. Ultrasound was done, CTG was done, all were normal. And then now the diagnosis would be severe gestational hypertension. So in case of severe gestational hypertension, our decision is to deliver, and delivery rather than expected management is usually followed after 34 weeks after stabilization of the blood pressure. So this is the recent guideline given in ACOG and up to date. And in the same case, the intrapartum care, because she has been induced, continuous electronic fetal monitoring and antihypertensive treatment was continued, and BP was measured every hourly and cut short of the second stage of labor, and avoid ergometry for the management of the third stage of labor was done. In the postnatal care, the BP antihypertensives were titrated depending upon her blood pressure, and at the time of the discharge, the plan for the follow-up was given to her. So now my second case is a 32-year-old patient. She came for a preconceptional counseling. Her BMI was 32. She was an asthmatic. Her mother had eclampsia, and she had a MET-X syndrome, and she was on tablet Telma. And I counseled her for weight reduction with diet and exercise, and I told her if you go for pregnancy, you need to take aspirin, and also because you are an asthmatic, you cannot take labetalol. That was just told because she was a friend of mine at that time. And at 35 years, she came back with 8 weeks of gestation. Her BMI was 28. So her BMI has come down by 4. She has stopped because she has stopped the antihypertensives because all the BP values recordings were normal. So I asked her, how did you reduce weight and for what did you reduce weight? So she showed me this chart where the weight reduction helps in decreasing the systolic blood pressure by about 5 to 20 millimeters of the mercury, and diet plan, sodium restriction, physical activity like about 20 minutes most of the days in a week, and these are all she has done, so her BMI has reduced. And regarding the risk factors, when do we start, is there a need to start aspirin? This has to be decided. So the risk factors we need to know. The high risk factors are the hypertensive diseases during previous pregnancy, chronic kidney diseases, autoimmune diseases, type 1, type 2 diabetes, and chronic hypertension. So the moderate risk factors are the primary, age 40 years or older, pregnancy interval of more than 10 years, BMI of 35 or more at the time of the first visit, and family history of preeclampsia and multiple pregnancy. So in this patient, the aspirin was started because one high risk factor was there, and even one moderate risk factor was also there. And ideally it should be started at 12 weeks, but according to ISHP 2018, it was given ideally it can be started at 16 weeks, and 150 milligrams per day of aspirin can be given. So Whenever we give aspirin, we need to monitor her more times. So BP monitoring is important and assessment of proteinuria is also important. So nitric oxide donors, progesterones, diuretics, low molecular weight heparins, magnesium, folic acid, antioxidants, fish oils, garlic, etc. do not prevent hypertensive disorders of pregnancy. Hence, all these supplements need not be advised to them. So, because I was thinking she can land in chronic hypertension, I have advised the plan for same what we give for a chronic hypertensive patient, that is low dietary sodium, optimal weight gain, the target blood pressure should be 135/85 and aspirin should be continued. The gestosis score has to be plotted and 2 weekly checkups or weekly checkups in case if she develops BP and depending upon her control, I would call her back. So the baseline investigations were normal and the weight and diet counseling has been done and calcium supplementation was also given. And then she came for a regular checkup, she was normal. At 16 weeks of gestation, she has developed 140/95 blood pressure. Both the readings were the same and the investigations were done, they were within the normal limits. So now we name her as a chronic hypertension because this is at 20 weeks of gestation. So as we all know, many of the physiological factors in pregnancy, they decrease the blood pressure during the second trimester. But here in this case, the patient has developed hypertension. So we ought to be cautious. And antihypertensives were started to achieve the blood pressure of 135/85. Same labetalol, nifedipine and methyl-dopa can be used, but the best one is the labetalol. So when a patient comes with the chronic hypertension, we have to schedule the appointments, and the important thing is we need to stop the ACE inhibitors or ARBs within 2 days of notification of pregnancy because of increased risk of congenital anomalies. As I said, we have to be careful regarding the complications like superimposed preeclampsia, fetal growth restriction, placental abruption and severe hypertension. So in this patient, my plan was to do dipstick testing, whether like she may become a preeclamptic patient, so dipstick testing, blood test at each visit, and fetal monitoring with symphysofundelhide, auscultation, serial growth scans 2 to 4 weeks, and plotting on the customized growth charts, and probably everything goes well to deliver at 37 weeks of gestation. So at 28 weeks of gestation, the BP was 135/85, but the protein was 2+, so we have to name her now as preeclampsia. There were no warning signs, there were no other complaints, the blood tests were normal. Antenatal corticosteroids were given, IM dexamethasone 6 mg 12 hourly for 4 doses, and review every 2 days for BP monitoring was the plan. At 30 weeks of gestation, the BP was 135/85, blood parameters were normal, and even the ultrasound was normal. So in view of like she may go for a complication, early delivery, Maxelf was given for neuroprotection. So this is from the NICE guidelines. The BP measurement has to be done depending upon the, like if we admit her, it has to be done every 48 hours. And the blood tests need to be done twice a week. That is CBC, LFT and RFT have to be done twice a week. And the fetal monitoring has to be done. And CTG, if indicated, like in changes in the fetal movements, vaginal bleeding, abdominal pain, deterioration in the maternal condition. So the timing of the birth depends upon the complications. So if it is better if we prolong the patient up till 34 weeks, but depending upon the premonitory symptoms and the diagnosis of hypertensive disorder, we have to go. So if everything goes, my plan was if everything goes good, that is if it is only a preeclampsia, and then I wanted to deliver her at 37 weeks with continuous fetal monitoring, antihypertensive treatment, and measure the BP hourly and avoid ergometrin. So in the postnatal period, if she is a preeclampsia patient delivering at 37 weeks, the aim was to maintain BP less than 140/90, measure her BP daily for the first 2 days and at least once between 3 to 5 days after birth, continue her natal antihypertensive treatment basing upon the titrations, and then avoid diuretic antihypertensives in case she is breastfeeding, and postnatal checkups every 2 weeks with BP monitoring and later on also. So this patient at 31 weeks, she came with a blood pressure of 170 to 120. She was admitted because it is a case of severe preeclampsia. And at 31, the same day, the next morning, she had a headache and the creatinine was 1.5 milligrams, ALT was 80 international units, that is more than 2 times, and the ultrasound was like good with 1900 grams fetus, and the Dopplers were normal. So we had started her on the injection because she was an asthmatic. We had to go for the hydralazine. So we need to deliver this patient because she's a case of severe eclampsia with premonitory symptoms. So now I would like to discuss what are all the managements in the severe preeclampsia. So the diagnosis of severe preeclampsia is 160 BP with 160 systolic or more than 110 diastolic with significant proteinuria, or absolute BP more than 140/90 with one of the following factors like headache, visual disturbances, dyspnea, clonus more than 3, platelet count less than 1 lakh, AST more than 70, creatinine more than 1 milligram per deciliter, and papilledema. So the extra investigations that we order once we diagnose as a severe preeclampsia are the coagulation profile, serum electrolytes, maternal ultrasound to rule out ascites and also to see the liver capsule, fundoscopy to rule out the papilledema, chest X-ray for pulmonary edema, ECG and echo. So the timing of the birth would depend upon inability to control the maternal blood pressure despite using 3 or more classes of antihypertensive drugs, maternal pulse oximeter less than 90%, progressive deterioration in the liver function as in this case, and neurological symptoms. 2 minutes. The principles of the management would be to stabilize the patient by controlling the blood pressure, preventing the seizures, and delivery by safest route. So the patient has to be transferred to the ICU, wide bore cannula has to be inserted, indwelling catheter with hourly measurements of urine, BP recording every 15 minutes for a minimum of 4 hours until the BP is stabilized, then half an hourly. Oxygen saturation has to be recorded, and proteinuria, if needed, can be done with the collected urine from the indwelling catheter, temperature every 4th hourly. And routine investigations, what we do for preeclampsia profile every 12 to 24 hours, or depending upon her condition, we may need to do more frequently. And central venous pressure in case if the patient is bleeding or if she is oliguric. So the blood pressure control is important, and the diastolic blood pressure should be between 80 to 100 and systolic below 150. The first line of therapy would be labetalol, second line would be the hydralazine. And Afro-Caribbean origin women are less responsive to labetalol, so we may need to go for the hydralazine. And the contraindications for the labetalol, as we all know, it is a cardiac failure and asthma. So this is a slide showing the antihypertensives and the doses. So the nifedipine can be given 10 to 20 milligrams orally, repeated every 30 minutes if needed, and then 10 to 20 milligrams every 2 to 6 hourly for a maximum of 120 milligrams. So the aim of the blood pressure, as I told, it is like 150, 100, and whenever we cannot access an IV line, we can give a 200 milligrams dose of labetalol. And prevention of the seizure is important because most of the cases they go for eclampsia. So this is done with the magnesium sulfate, and magnesium sulfate is indicated if one or more of the following features are present along with the severe preeclampsia, that is ongoing or recurring severe headache, visual scotomas, nausea, epigastric pain, oliguria, and progressive deterioration, the laboratory test. So we all know the Pritchard's regime and Zussman's regime, and the fluid balance is very important. The patient should not go for oliguria, or she should not land with pulmonary edema. So the objective is to maintain a minimum urine output of 100 ml in 4 hours, and 80 ml of Hartmann solution is given intravenously, and the balance should be well maintained. So anesthesia is regional anesthesia is best, but the coagulation screen should be normal, and also the platelet count should be more than 1 lakh, and the no preload has to be given before the regional anesthesia. And if these criteria do not meet, then we have to go for a general anesthesia. NSAIDs cannot be used because this cause renal failure. And we need to continue most of the protocol in the next 24 hours after the delivery. And important thing is the anti-embolism stockings should be given to her. And if we need to start low molecular weight heparin, then the platelet count has to be measured. It should be more than 1 lakh. And postnatal care, again, it is important because she may again go for eclampsia, so the blood fluid balance and the breastfeeding has to be continued. And we all know the complications of the preeclampsia, so we have to be very cautious. And we know the protocols of eclampsia also maintain the airway left lateral position. Oxygen has to be given to the patient. And in case of the HELP syndrome, the important thing is delivery of the fetus is the correct treatment. And in summary, we have to aim at the target blood pressure of 135 by 85. And in any case, we see a obese patient, we need to counsel her for pre-pregnancy time. And also we need to follow all the hypertensive patients in the till postnatal period. And the warning symptoms have to be told properly to all the hypertensive patients. And we need to anticipate the complications and refer to the higher center. And recurrence has to be told to all the patients at the time of the discharge that it is about 20% of recurrence of hypertensive disorders in pregnancy. There is no role of supplements. And the prognosis has to be explained to the attenders with all the caution of medico-legal issues. And let's all strive for a decreasing maternal mortality due to the hypertensive disorders in pregnancy. Thank you all.
Hello, thank you, madam. Very nice and case-based.
Now I request Dr. Lakshminaranamma madam to present memento to Dr. Sushila ma'am.
Hello, hello. Hello.
Good afternoon, everyone. It's my privilege to introduce now Dr. Professor Indranil Datta. He is a professor in Medical College IQCT and NH Durgapur, West Bengal, and is immediate past president COX FOXY and ex-member Y2P committee FOXY and past East Zone coordinator 2020-21 under FOXY president. And I am a standing committee member for antimicrobial resistance 2018 to 2022. And he has published more than 40 articles in various index journals and articles of reputed, including in PubMed database and Cochrane database, and contributed chapters in 20 FOXY books, including one international book in Jeff Cott's Gynecology, and editor for 2 books, including FOXY Focus on Drugs Update, and organized 5 FOXY conferences in Calcutta and 10 other CMAs and local body conferences, and member of FOXY, IMA, SAFOG, ISR, IAGE, and ASPIRE, Asian Pacific Initiative on Reproduction, and is also a winner of several prestigious awards in endocrinology, then awards for laparoscopy and oncology, and many more. Welcome, sir.
Thank you, madam. And first of all, I would like to apologize for delay in my timing because of my visit to Mandir today, which had to be done. Secondly, I would like to thank the organizing committee for giving me this huge opportunity to come again to South because of my soft corner for southern part of India, particularly because I have studied here. So with this and the blessing of God, I will start my session. We all know the protocols for cesarean section. We all know the steps. We know the problems related to C-section. We have been discussing it again and again over many conferences. This particular responsibility has been given to me to again regularize and familiarize with the standard operative protocol which has to be followed for C-section. This is just to revisit and relearn about what we already know. So coming to introduce, we will be dealing with the minimum standards of care expected in a particular case of cesarean section, procedural aspects, the preoperative requisites, the type of anesthesia, skin incision, uterine incision. There will be a lot of controversies with these discussions. We will not go into controversy. We will go with what our parent society, FOXI, has suggested, as well as some few international societies also. Delivery of the baby, closure, post-op care, hospital stay, discharges, follow-up, training and audit, and checklist. So, cesarean section is primarily the lower segment, particularly the lower segment cesarean section is one of the most commonly performed operations. We all know this. With the evolution in the anesthesia and antibiotics techniques, the operative skills, the availability of blood, it has become much safer compared to previous days, which we all agree now. India is a vast country and there are various types of hospitals depending on the geography. Like I work in the rural area, like that there are hospitals in the urban area, hospitals in the rural area. The economics and the availability of trained personnel is still a big issue in the rural area. The public, private or the trust hospital, teaching hospitals, nursing homes. So there are various strata of healthcare system present in our country and we have to identify the places in which particularly where the patient may require a higher care. That is why Government of India always proposes minimum of antenatal visit for all the patients, at least in a tertiary care setup in case of emergencies. And otherwise, we don't want the MMR rate to be high. Now coming back to the topic again, the guidelines cannot possibly include all the clinical scenarios. Hence, the individualization may be necessary as demanded by situations. So what do we mean by this minimal standard of care? We all know the steps, but the particular standards of care has to be regularized for all the patients and it has to be regularized from our end also, that is the surgeon's end also. We need to follow some standard of care for the patient. The basic thing, the first and the most important point is information to the woman. Now we know the basic problem is, like in a busy hospital setup like this, it is impossible where in OPD you get hundreds of patients and it is impossible for you to particularly look into particular patient and start giving all the information in detail about the pros and the cons of any surgical procedure. Now considering this, we are still considering this time of medico-legal problems which we all are facing now, which was not there earlier, which was not much as now it is. We have to provide some information to the woman so that she also gets minimal standard of care and we also are able to deliver that. Planned cesarean section now, and I don't know about particularly this state, but in West Bengal already we have got a government circular regarding after every C-section we have to provide a 7-page detailed report about why we went for that cesarean section. So there, from last 3 months, that is a task which has been given to any surgeon in any nursing homes and in any hospitals have to provide that detail at the end of 7th, at least within the 7th of next month. So this is how the government is looking into the matter of increased cesarean section. Procedural aspect and the care of the woman. Now coming to the information to the woman. The pregnant woman should be offered evidence-based information, very important, and support to enable them to make an informed decision. Now why this evidence-based information is essential? Because we know that currently, suppose by mistake we are stuck into some legal issue in which we know that we have not committed the crime or problem, but the court follows the book and the evidence. So this evidence-based guidelines and evidence-based information has to be provided to the patient regardless of how busy we are. That is the most important thing which has to be taken at this point of time. Information has to be shared during the antenatal period, including the indication for the LSCS, what the procedure involves, associated risk and benefit, and implication for future pregnancies and birth after C-section. Place of birth, decision making of C-section, these all are already, we all take care of that information. Now coming to the urgency of the cesarean section. It should be determined and has to be categorized in the following manner, that whether it is immediate threat to the life of the woman or fetus, so that the C-section has to be done immediately, whether there is a maternal or a fetal compromise which is not life-threatening, no maternal or fetal compromise but needs early delivery and planned delivery. So category 1 and 2 requires the first procedure to be done. We all know the maternal indication. I'll go briefly through that. Gross CPD, major degrees of placenta previa, obstructed labor, deep transverse arrest, previous LSCS cases, abruptio placentae, previous uterine surgery, or premature rupture of membranes more than 24 hours. So some of these are recurrent, some are non-recurrent causes. We know those details and we know these indications. Coming to the fetal indication, malpresentations, particularly transverse, oblique and mentoposterior, pregnant woman with a singleton breech, term breech presentation, big baby, footling presentation, stargazing fetus, complicated breech delivery may sometimes warrant fetal as a part of the fetal indication. Fetal distress, cord prolapse and fetal diseases also play a role. Now coming to the other indication. One important point we know is cesarean delivery on maternal request. Now this is a controversial point because till now, like as I told, West Bengal government has taken this in hand. Even the government hospitals cannot refer them directly to some other setup, considering that due to unavailability of the surgeon or anesthetic, they cannot just refer. For everything they have to provide that 7-paper sheet. And why, even if the patient lands into C-section in some other hospital, so the previous hospital also has to justify. So these are the norms which are coming, particularly this maternal request. Cesarean delivery is very controversial at this point of time, but we know that occasionally C-section is requested by pregnant women, and this has to be followed by a balanced counseling of the risk and benefit of the C-section with the vaginal delivery. The decision made by the patient should be respected. Now coming to the maternal infection, some of the C-section can be as an alternative to reduce mother-to-child transmission. I don't mean that every HIV patient needs to be done C-section, no. But yes, some typical conditions in which the RNA levels are more than 400 copies, or there is a co-infection in which we suspect that there may be a transmission from mother to child, or primary genital herpes simplex cases if the PROM is within 4 hours. So these are some of the special indication in special cases in which we can go for C-section. Now coming to the consent. Now when we talk about standard operative protocols, consent plays an important role. It has to be requested after providing the pregnant woman with evidence-based information in a manner that respects the woman's privacy, views, culture, while taking into the consideration the clinical situation also. Consent should be taken in the language as understood by the patient, should be explained that though techniques of anesthesia and surgery are advanced, yet there may be complications of the anesthesia, like so wise everything has to be mentioned in the consent paper. And nowadays it has been observed in certain cases that printed consent form is not being encouraged by the courts of our country also. Printed standard form is not being accepted as a routine care, which many hospitals, even in some of the hospitals in which I work, also follow that printed consent form. So there is a dicey situation there. Now, however, all possible precautions has to be taken by the team of doctors to minimize the complication. In case the patient is unable to sign, then a thumb impression can be taken. If the patient is not in a position to give consent and consent should be obtained, then consent can be obtained from relatives. In case of less than 18 years, guardian consent is necessary. 100% favorable outcome of the mother and the baby is never guaranteed. The patient may opt for refusal of the C-section, being oblivious of the benefits to her and her baby's health. Despite this, if there is a refusal of the consent, it must be documented on the paper. If the procedure is life-saving, I mentioned if it is life-saving, then C-section can be performed without a valid consent. Now coming to the procedural aspects, we know the basic investigations, the routine investigations like hemoglobin, blood grouping, all the serology, urine routine has to be kept in hand. Cross-matching is recommended in particular cases like Rh negative, severe anemia, placenta previa, adherent placenta, and many complications like coagulopathy, sepsis, and so on. Non-availability of the blood should not prevent an obstetrician from performing the C-section for emergency condition. Now, again, this is a very problematic situation because we know that sometimes the patients are being referred from hospital emergencies to maybe a higher setup in terms of that blood is not available. That is wrong. If something happens to that patient, or if the patient has some issue on the way, or even if later on, due to this non-availability of blood related cause, you may be in soup because of this reason. So, IV line has to be taken with a large bore needle, antibiotic can be decided, and standard protocols of antibiotic can be followed as per WHO guidelines also. Preoperative requisites for the standard protocol, obviously the theatre should be clean, adequate space and ventilation should be there. Emergency drugs and equipments should be in working condition, that is the work. If you are the hospital owner, then it becomes your headache, or if it is a big hospital, the superintendent ultimately has to face the questions if something is wrong. Adequate sterile linen, gowns and other supplies should be available. All the staff working in the areas, particularly labor room areas, should be trained about the systems management, and following apparatus should be checked regularly and ensured to be in working condition, like the Boyle's apparatus, BP apparatus, pulse oximeter, cautery, suction machines, availability of the continuous supply of the oxygen and other gases. For the newborn, the arrangement should be made for suction machine, sterile tubing, laryngoscope, endotracheal tubes, overhead light or the warmer. Anesthesia type can be decided by the anesthetist and the obstetrician in conjunction with the patient. Spinal anesthesia is reliable, again we know this is our same knowledge which we are revisiting. Has rapid onset, patient is awake and less risk of aspiration compared to the epidural which has less of hypotension, and good post-operative analgesia can be offered. General is only used when regional is contraindicated and in particularly high-risk cases, in cases of sepsis, severe hypotension, thrombocytopenia, coagulation disorders, and so on. Coming to the skin incision, there has been some sort of minimal controversies in the type of the skin incision, but the commonly done one is the phalansteal incision. It is a curved skin incision, 2 fingers above the symphysis pubis. It is associated with less post-operative pain, has cosmetic appeal and low wound dehiscence and less chances of herniation. Transverse, the Joel Cohen's incision is a straight skin incision 3 centimeter above the symphysis pubis, and here the subsequent tissue layers are opened bluntly, that is the scissors are used for extension and has shorter operating time and reduced post-operative febrile morbidity. Particularly this incision is given in case where we want a fast in and fast out in the delivery process. Vertical incision, it is the traditional one. It was used previously extensively. Now it has been avoided mostly because of the post-operative pain and the low cosmetic appeal and more chances of hernia. Coming to the uterine incision, important surgical step, and it has to be planned pre-operatively. Commonest, the lower segment transverse incision. It is commonly used. 1 to 2 centimeter is usually cut and extended transversely with the scissors or digitally when the lower segment is well formed, and blunt rather than sharp extension of the incision should be done as it reduces the blood loss. Intraoperative hemorrhage and need for blood transfusion also gradually is reduced. Lower segment vertical incisions, it is not commonly used. It can be done only in cases where poorly formed lower segment or preterm patient. Sometimes this incision can be an option, but it is again, as I mentioned, not commonly used. Classical incision is rarely used except where the access to the lower segment is not possible, like some anterior wall huge fibroid with maybe placenta previa. In particular cases, we may have to go for the classical type. Coming to the T-shaped incision, it may require, if required, J-shaped or U-shaped incisions are preferred to the T-shape. These incisions may be required in cases of difficult deliveries also. Coming to the delivery of the baby, maintaining the flexion of the fetal head during the delivery reduces the diameter and eases the delivery process. It also reduces the undue extension of the uterine incision and the excessive hemorrhage and the time required for C-section also. Very important, one must avoid a hasty baby delivery, and the skilled operator is required for delivery process, particularly in cases when you are dealing with floating head, deeply engaged head, or malpresentations like breech, transverse lie, or multifetal pregnancy or premature babies. During C-section, skilled personnel should also be available for the neonatal side also. Few difficult delivery situations may be there, like high floating head, deeply engaged head, and breech. Briefly to mention, in high floating head, rupture of the membranes followed by suctioning of the liquor and allow the vertex to descend to the incision site and get fixed at that site, it will enable us to deliver the baby in a better manner. And then you have to flex and you can conduct the delivery either using your hands or using the vacuum also, if you are comfortable with that. Deeply engaged head, disimpaction with the vectis or manually sometimes may lead to deep injury. That's why commonly used maneuver is Patwarson's maneuver, which is appropriately used if it is known by the operator. Coming to the breech delivery, should be delivered with the same care as in vaginal breech delivery. Head can be delivered by Burns-Marshall or the Maricchio-Smelly-Wheat method. Closure, uterine closure, again the controversy regarding 1 or 2 layers, but ultimately we have to ensure the adequate approximation and hemostasis, which is most important. Peritoneum need not be sutured in particular cases, but I personally stitch the peritoneum only in cases where severe emergency is there and you have to go for fast in and fast out. Maybe that time you can leave off the peritoneum. It depends from individual surgeons to surgeons. Coming to the closure of abdomen, rectus muscle, gentle approximation with the interrupted chromic catgut or polygalactin is done. Rectus sheath is most important structure for the integrity of the abdomen, hence non-absorbable or delayed absorbable suture is recommended. Similarly, vertical incision should also be closed with non-absorbable sutures. Subcutaneous tissue and the skin can also be used with absorbable or non-absorbable subcuticular type of sutures. Now, how do we minimize the blood loss and prevent PPH? We all know the role of the oxytocin, and we know the role of the control cord traction, particularly which is done in the vaginal delivery. Same procedure can be repeated in the C-section also, and oxytocin, as advised by the various guidelines around the world, can also be followed. Newer role of carbetocin has also increased in current times, and various studies and various companies are flocking to you with the particular drug. More studies are required in that regard also. Very, very, very important is checking the count. No matter in what sort of emergency you are, the count has to be taken by you at the beginning, in the middle, and at the end. This thing has to go in our head, being surgeons, because any small mistake, and no matter whatever good you have done to the patient, will not count in the court of the law. Three separate counts are recommended. First, when the instrument and the sponges are first unpacked and set up. Second, when the beginning of the surgical procedure. And third, as the closure begins. Post-operative care, use of oxytocin, prostaglandin, ergometrin can be used per se patient-to-patient basis. Patient is kept nil by mouth for 4 to 6 hours only. Early ambulation should be done. Oral fluid should be started as early as possible. Patient should be offered analgesia whenever she demands it. IV fluid should be given and soft diet can be advised. These are the part of the protocol, but we are going through the protocol, that's why I have to mention all these. Soft diet is advised once the bowel sound appear and or the patient feels hungry, and for monitoring the pulse, the BP and the respiratory rate for the first 2 hours and hourly thereafter for 6 hours if these are normal. Women should be catheterized to monitor the urinary output, and breastfeeding is also initiated very early as possible. Hospital stay and discharge. Hospital stay, usually because of the cesarean section, the hospital stay actually is increased, but in vaginal deliveries we usually release the patient on the second day. On the average, the patient is usually in the ward for around 3 to 4 days. Wound is checked prior to the discharge. If the pulse, BP, temperature, lochia and the breast examination are normal, patient can be discharged. The hospital record should be updated and the patient should be handed over the detailed record of the procedure and post-operative period and the follow-up instructions very clearly. Follow-up, routine follow-up is advised after a week for examining the wound and the abscess assess the breastfeeding status of the patient. Follow-up visit should include the discussion about the contraception. Training and audit, the operator should be well trained in carrying out the procedure. Audit is very essential to ensure the quality and the monitoring outcome. It should include the rate of cesarean section, indication of the cesarean section, and complication of the procedure. Audit should be done for the surgeon as well as the entire unit. Now coming to the last few slides, the checklist. So what pre-op checklist we have to follow, that is to do and to confirm. When the patient is on the OT table before starting anesthesia, the name, diagnosis and the procedure has to be mentioned. Pre-op instructions followed whether she is nil per mouth, whether medicines, any other medicines which she takes, which has to be known by the anesthetist, or whether any medicine needed to be withdrawn. Though in pregnancy we cannot ensure all these things because sometimes or maximum times the patient land in emergency, but still all information has to be elicited. Pre-operative investigations are done and checked. Pre-op check by the physician, anesthetist is done. Consent has to be again rechecked, and if blood is required, blood has to be cross-matched. Risk factors like social, medical and allergies to be considered. Pre-op antibiotic has to be given. Usual drugs which are contraindicated has to be, if they are considered, has to be mentioned in the checklist. Additional equipment like drain catheter, epidural catheter has to be kept. Trolley checkup for particularly MOP instrument, and the baby preparation is done for the resuscitation equipment, the warmer, the baby records and the neonatologist. Everyone should be in the checklist and should be checked. Coming for the post-op checklist, before the patient is shifted out of the OT, the sponge and the instrument count has to be checked, as I already mentioned. The pulse, BP and the oxygen saturation and PPH has to be ruled out. Urine color and the output needs to be mentioned. The urine at the end of the OT needs to be documented. If in case the cord blood was sent for some investigation, that has to be mentioned. And for the if there are multiple deliveries in a busy setup, obviously if the baby is put on the warmer, the marking and identification tag on the baby has to be put. And lastly, the anesthetist permission should be taken for shifting the patient out of the OT. So these are the SOPs for the cesarean section. I hope I have summarized it in whatever time I have got for the presentation. With this, I would like to thank you, madam, for this opportunity.
Yes, sir. Thank you, Dr. Datta, sir, for your nice presentation about its division of cesarean section program. And any questions from the audience? Thank you, sir.
Now I would like to invite Chairperson Kiranmai Madam. Sir, just wait, sir. Sir, Indranil, sir. To give memento and certificates to sir. Please, madam. Madam, you can also come. I request other chairpersons also to come, madam. Next, we will move on to the next session.
Now I am introducing Dr. Priyank Roy. He is Assistant Professor in Lord Buddha Koshi Medical College Hospital, Saharsa Consultant Infertility
and Gynec Endoscopy, Roy's Clinic and Nova IVF, Siliguri. Joint Secretary, Siliguri OBG Society, Joint Secretary, IMA, Siliguri Chapter, Vice President, Wartag Figo, Joint Secretary, Yes Dosis India Chapter, National Coordinator for Public Awareness Committee, FOXY. Sir has many list of awards. He has a few of them were FOXY Korean Award, Joint Category 2017, FOXY Future Award 2017, Shah S. Ratnam Young Gynecologist Award in 2019, and FOXY Dr. Kamini Rao Oration Award in 2020, and Shanti Yadav Award in Infertility in 2020, and Sun Traveling Fellowship in 2020, and Nimish R. Shihat Research Award in 2020, and Kumud Research Award in 2021. We welcome you, sir.
Thank you so much, ma'am. Good afternoon, everyone. It gives me immense pleasure to be standing in front of all of you here at this annual conference of the Andhra Pradesh chapter of Obstetrics and Gynecology. And I would say I'm also sorry for being a little late today because of the darshan, and thank you for adjusting this time for me. So the talk for me today is antepartum fetal surveillance, one of the very important topics that we know we use on a daily basis. So with the permission of the chairpersons, I would like to start my talk. Thank you. So first of all, I would like to start with a disclaimer to say that the time limit given to me is 30 minutes, so please do not expect me to finish in 15 minutes. And I will be trying to finish within this 30 minutes of time slot that is given to me. So I would start with this quote of our past FIGO president, Professor Muhammad Fathallah, who once said, "Women have a human right to go safely through the risky journey of pregnancy and childbirth, a right that should be respected, protected and implemented. And who better than us obstetricians to help our women go through this journey safely without much of our problems." And we know very well, if we have to help our women go through this journey, especially in obstetric cases, we will have to allow them, or we will have to get a good antepartum fetal surveillance done for them for the same. So the objectives that we'll go through in this presentation over the next half an hour are to learn interpreting the results of the fetal heart rate tracing, to learn the techniques for performing biophysical profile as well as the modified biophysical profile, to find out the association between the presence or absence of each of the components of biophysical score and fetal demise, or rather I would say fetal distress if any, and learn the appropriate response for test results based on the procedures. So antepartum fetal surveillance, the goal we all know is to prevent fetal death. The modified biophysical profile is an abbreviated biophysical profile that includes only the non-stress test and the amniotic fluid index. Normal results is a reactive NST with the AFI which is more than 5 centimeters. ACOG and the AAP in 2012 stated that antepartum fetal surveillance is for prevention of fetal death and also for avoidance of unnecessary interventions. I think coming to today's scenario, avoiding unnecessary interventions is something that we are really looking forward to. We are in a state where we are landing up with a lot of cases of placenta accreta spectrum because of the number of cesarean sections that we have done over the last decade or the last couple of decades. And it is really time for us now to check that with good antepartum fetal surveillance so that we do not land up in trouble for us in the future and do not let the next generation of gynecologists who will come up curse us because of the cesarean sections that we have already performed. So the parts, the different aspects of the antepartum fetal surveillance that we'll talk of. Daily fetal kick count is one of the very important factors which some of us may disregard or some of us may think is not important. But please do understand that daily fetal kick count is one of the most important aspects that we can talk of when we are talking of antepartum fetal surveillance. The Cardiff count of 10, and remember it is to be counted 1 hour after each meal, which is so very important. Please do not tell your patient to count the fetal kick count the whole day because it's not humanly possible for anyone to do the same. It's very important, this is especially for the postgraduates, very important for a patient to check it only for 1 hour after each meal, and remember that it should be a minimum of 8 to 10 counts, and that is appropriate for her at the gestational age at term. So the minimum number of maternal perceived fetal movements is consistent with the fetal well-being, and more the number of kicks the better it is. But then also remember, if the kick counts go more than 25, that is again not something that is good, and that also you will have to tell the patient to report to you if within these 3 hours the patient has a kick count of more than 25. So looking at the significance of the kick count, it is diminished fetal activity may be a harbinger of impending fetal death. Any pregnancy may become high risk at any point of time, that of course we all know, and diminished fetal activity is important in all cases. Now talking of the second line over here, any pregnancy may become high risk at any time. It is a situation or a state where the pregnancies which we expect to have least complications are the ones which have maximum number of complications most of the times. So it is best for us to try and treat all pregnancies as high risk pregnancies and do the maximum monitoring as much as possible without doing any interventions. Fetal monitoring by auscultation. I am sure all of you do this auscultatory method still. I was talking to my dad the other day. He is also a gynecologist, and he tells me, today you might be thinking that laparoscope is your one hand and ultrasound probe is your other hand, but believe me, in his days he talked about where they could even diagnose. I'm sure many of the teachers who are present over here did the same, where they could diagnose things more clinically than they had investigations for. Even he used to tell me that they have done cultosynthesis etc. for diagnosing ectopic pregnancy, which I'm sure many of us do not even think of nowadays. But those are modalities which can definitely be used, and those are modalities which actually help us in diagnosing or treating a patient as a patient and not as a robot or as a human. So the FHR monitoring by auscultation, as stated by Miller in 2015, talked of intermittent auscultation is a skill that is not simple. It is a rightfully complex and time consuming and must be performed with care and precision, no different from the appropriate use of electronic fetal monitoring. So please make sure you put your stethoscope on the patient's abdomen, or at least put your Doppler probe on the patient's abdomen and hear the fetal heartbeat. As soon as the patient comes, do not make her lie down on the bed and put an ultrasound probe on the abdomen to check for the fetal heart sound. Because I understand that may also be done, but then it's also equally important considering the medical legal aspects of filling up the Form F etc. for every ultrasound that you do. It's so very important for us to have a clinical acumen also, check the fetal heart sound by stethoscope as well as by the Doppler modality. Now, one of the most important antenatal fetal surveillance modalities, the non-stress test, which I am sure all of us do routinely in your day-to-day practice. It is performed by auscultation of the fetal heart rate using an electronic monitor. It is the ultrasound probe and the pressure transducer which helps us in monitoring the fetal heart sound, in which we'll have to look at the various aspects of the acceleration, deceleration, variability, etc. And with the pressure transducer, we'll have to look for any increase in the intra-abdominal pressure, or rather any contractions that are present, which there'll be a spike for, and which will tell us any contraction that the patient is having or undergoing. Remember, when you are doing a non-stress test or an NST for a patient, it's very important for us to set the correct speed, at which the paper will also roll. Because you will find sometimes when the paper is rolling at a very fast speed, you will find that the accelerations will just look like a variability and will not look like acceleration. So set it at the correct pace, where each vertical square is 10 beats, each small horizontal square is 10 seconds, and each large horizontal square is 1 minute. If you set it at the correct rate, you will see you will get a good graph of the accelerations, of the variability that we need to know to do surveillance, to have a proper antepartum surveillance for our patients. Now, of course, we all know how to interpret a fetal heart tracing, but just to go by a few guidelines, that is the NICE guidelines, etc., which will tell us about how better to do the intrapartum fetal heart rate tracing. So we need to look at the baseline fetal heart rate, we need to look at the variability, the accelerations, the decelerations, and also few atypical trends that are seen in time in certain cases, and also if there are any frequency and intensity of the uterine contraction and its role with the deceleration in case if it is present. So the basal heart rate, of course we know, is the fetal heart rate during a 10-minute segment. Now for the postgraduates over here, please do not take only a 2-minute segment of it and say that the NST is not reactive. Remember, you will have to take a NST for a minimum period of 10 minutes to say whether it's reactive or not. In case if you do not have a reactive NST in 10 minutes time, remember you will have to continue this NST for a period of 30 minutes. That is what our FOXI guidelines as well as the European Society guidelines talk about when we talk of antepartum fetal surveillance, because we know that a baby sleep cycle is approximately for 23 to 24 minutes. So if you repeat a cycle for an entire duration of 30 minutes, you will get that required acceleration which may or may not be present. If it is not present, that is when you may talk of it being a pathological NST. So basal heart rate we all know how to check, and of course that is sort of the average of the baseline that could be present. There could be cases where you can have bradycardia. We all know the normal FHR being 110 to 160 beats per minute, and if it is less than 110 beats per minute, it will be a case of bradycardia. A rate of 100 to 119 beats per minute is in the absence of other non-reassuring patterns is not usually a sign of compromise. This is the latest addition that has been given by the American Society guidelines, where they talk of 100 to 119 being a gray zone, and if there is nothing else that is present, then we can take it as, or we can repeat it after a couple of hours after the patient eats something to see whether the reassuring pattern comes back. There could be causes of bradycardia pathologically, heart block, occipito-posterior or transverse position, especially if the patient is having some bit of contraction, and serious fetal compromise can also be present. Patients with new onset bradycardia should be monitored closely. So if you have had taken an NST 6 hours before, which looked completely normal, and if you are repeating an NST after 6 hours and you see bradycardia developing, those are the cases where you will have to definitely look into whether there are something else, some other compromise that is setting in that could be problematic for us as well as for the patient. Now, tachycardia, fetal heart sound, of course more than 160 beats per minute. In the presence of good variability, tachycardia is not a sign of fetal distress. But remember, the time duration when you talk of tachycardia is 90 minutes. So in case the duration of tachycardia persists for more than 90 minutes, we will have to take a call of whatever we need to do next. In the meantime, of course, check for the various other aspects like maternal fever. We can also check for any dehydration etc. for the patient as well, which can also lead to a bit of tachycardia. The other routine causes of tachycardia, that is the pathological causes, could be fetal hypoxia, fetal anemia, amnionitis. It could be even a normal variant, and also fetal tachyarrhythmia, usually of more than 200 beats per minute with abrupt onset, little to no variability. Now this is the case, 200 beats per minute with little to no variability lasting for more than 60 to 90 minutes is something which is absolutely pathological by the light criteria as well, and we have to take up for a immediate intervention as soon as possible. So this is a graph where you can see a tachycardia, you can see the baseline which is set almost at 180 rising to 190 beats per minute, and that is not something that is normally to be accepted. Variability, I am sure all of us know, is the most important factor, because when you have tachycardia, if you have tachycardia, if you don't have tachycardia, if you have bradycardia or not, you have a normal pattern, but you will look at variability. Even if you don't have accelerations, if you have good variability, you can still hold on, and you can not press that panic button yet, and you can say that we can hold on for some more time. So variability, the grades of fluctuation are based on the amplitude range, that is peak to the trough. A sinusoidal pattern has regular amplitude and frequency and is excluded in the definition of variability, the graph of which I will show you subsequently. So for the postgraduate especially, this is the slide that I wanted to put in for you. Minimal, moderate and marked variability is what we talk of. Minimal, less than 5 beats per minute, which you can see in the second pointer nahi hai na? Which you can see in the second graph over there. Which you can see in the second graph over there. The variability is very, very minimal. Moderate is 6 to 25 and marked is more than 25 beats per minute. Now this is what is ideal. This is not very good but not very bad either. But if this pattern persists for a very long time, that is not something that is to be accepted, or that is something that could be pathological. And absent variability is this, almost like a flat line, which is again not something that is to be routinely accepted. So the presence of moderate FHR variability is reassuring, as I have already mentioned. Persistently minimal or absent FHR variability appears to be the most significant sign of fetal compromise. As we have talked about, in case there is acceleration or no acceleration, if there is deceleration or no deceleration, whatever it be, but if variability is absent for a longer period of time, that is the most important factor when you talk of fetal compromise. On the other hand, the presence of good FHR variability may not always be predictive of a good outcome, such as may occur in cases of abruption as well. We know that in case of abruption, the whole the NST can be very reactive and can become non-reactive very soon. So it is sort of a pathological misnomer, but normally if you see in a routine number of cases, you can talk about variability being the most important predictive factor. So what are the causes of decreased variability? Number one, the foremost factor, fetal metabolic acidosis, and that is why comes the importance. In case the patient is in labor, you do not have variability for a long time, that's when we talk of scalp pH being one of the factors that can be done to rule out acidosis, to rule out complications, because we know less than 7.2 of a fetal pH can be bad, and if it goes less than 7.1, it is absolutely disastrous. CNS depressants, if the mother is taking any, if there is any fetal sleep cycle, which I again said is for a time of 23.6 seconds approximately, so you have to wait for longer than that if you have to look for variability. Could be congenital anomalies, prematurity, fetal tachycardia, pre-existing neurological abnormalities, as well as in cases can be normal variant, but I think I personally do not have the heart to think that absent of variability for more than 90 minutes is a normal variant, and I will still wait on or look for variability even after that. Maybe we'll repeat a NST after she eats after 2 to 4 hours, but then again, if the variability is absent, then it could be a person with a very strong heart who will still wait on to think that things will still get normal. Now, we did talk of the sinusoidal pattern and the pseudo-sinusoidal pattern. Now, this first graph that you can see over here is a typical sinusoidal pattern where you have that curvilinear sort of a line. Please do not consider this to be accelerations, and do not think that this is something normal. This is a line where there are no accelerations. This is absolutely zero variability, and it is just showing a sinusoidal sort of a pattern, which is not something that is to be accepted, or that is not something that is good. Pseudo-sinusoidal is usually caused by drugs, and you can see this pattern over here, small bits of sinusoidal sort of a pattern, which is not exactly sinusoidal, and you can still make out some bit of variability in the pseudo-sinusoidal patterns. This is a normal sort of NST where you can see a good fetal basal heart rate with accelerations, no decelerations, and good variability that is present, and that is our NST. That is something that is normally accepted. A no variability graph, again, as you can see over here, this is a very minimal variability that is less than 5 beats per minute, a one with a moderate variability that is 5 to 25 beats per minute, and this is increased variability of more than 25 beats per minute. A saltatory pattern that you can see over here, almost similar to a sinusoidal pattern, in which you can still see some variability, but it is not something that is physiological and can in some cases considered to be pathological. We know what accelerations are, so I will not go into details of it. I will just mention the last line. The absence of accelerations for more than 80 minutes correlates with increased neonatal morbidity, but again we have to look into the factor of increase in variability or normal variability in these cases, which can still prove that these cases are not can be also physiological. Now, this is a graph showing a fetal heart rate acceleration based on the weekly gestational age. So at 60 weeks, you can see the acceleration is not much, but when you come near term, you can see that almost 90 to 100% of cases will have acceleration, very good accelerations, and that is what is considered physiologically in these patients. Reactivity, NST is considered to be reactive if there are accelerations, no decelerations, good variability that is around 5 to 25, moderate variability that is, and if these are the factors that are present in a NST over 10 to 20 minutes, then that would be considered to be a normal NST. In case there are no accelerations seen or no variability seen, then we can go back to that age-old technique of the vibroacoustic stimulation or the VAS. If the pattern is not reactive after 20 minutes of observation, then vibroacoustic stimulation, VAS, using an artificial larynx may be performed. Now, how is this performed? The stimulator should be positioned on the maternal abdomen, and a stimulation of 3 seconds or less applied near the fetal head. Please understand one thing: do not keep ringing the bell or whatever you are keeping to give this vibroacoustic stimulation, because there has been a report of a couple of cases where because of excessive stimulation there has been abruption that has occurred. So keep it for a period of only 3 to 5 minutes and nothing more than that. So how reassuring is a reactive NST? The interpretation of a reactive NST basically. A reactive NST has been associated with a perinatal mortality of approximately only 5 in 1,000 patients. The false positive rate is the test indicates fetal compromise when the fetus is actually alright. Associated with non-reactive NST is approximately 75 to 90%. That means it has got a very good value, and the malformed fetuses have a higher incidence of non-reactive NST, and we know this. Likelihood of a non-reactive NST. A non-reactive NST is one that lacks sufficient fetal heart rate accelerations over a 40-minute period. Overall, on initial testing, 85% of NST will be reactive and 15% will be non-reactive. Remember, approximately 15% of NSTs remain non-reactive between 28 to 32 weeks because of course, the autonomous nervous system that is not very fully developed. So do not do a NST in 30 weeks, 31 weeks and think that it is not reactive and you are taking our patient for cesarean section. Please repeat it 32 weeks onwards, because that's when the nervous system is fully developed, and that is when it will give you the actuals based on the stimulation or the acceleration or the variability in the baby. A non-reactive NST requires surveillance with biophysical profile. Of course, we know this. Decelerations can be variable, can be gradual. Can be further classified into early as well as late decelerations. Now, variable decelerations are the ones which are initially physiological, but it persists for a longer time. That is when we may consider them to be pathological. The onset of deceleration to nadir is less than 30 seconds. You can see in the graph over here that the deceleration, and within 30 seconds it again comes back to normalcy. The deceleration lasts for more than equal to 15 seconds and less than 2 minutes of period is what is a variable deceleration. Now, if you look at early deceleration, it's a gradual decrease in the FHR with onset of deceleration to nadir of more than equal to 30 seconds, and this is a sort of a shallow sort of a curve. Usually you will see due to the cervical dilatation in the early labor, around less than 3 centimeter dilatation is what we call it as a early deceleration. Now, late deceleration is something that is ominous in some of the cases. In this, the onset of deceleration to nadir is more than equal to 30 seconds. You can see the slow recovery, and always remember one thing: when you have a slow recovery of a late deceleration with an overshoot, that is something that is absolutely pathological and needs to be considered very, very seriously to prevent fetal morbidity and mortality. So this is another graph where you can see a late deceleration. You can see over here the sort of a zero variability pattern with this decelerations happening, and this can be, in most of the cases, can be pathological. This is another pattern you can see over here, absolute zero variability with late decelerations, and that has to be, looks like if the patient is not in late labor, has to be taken up for a cesarean section at the earliest to prevent complications. Now, there is another entity which is called prolonged decelerations. That is the decelerations which is a decrease in the fetal heart rate of more than equal to 15 beats per minute measured from the most recently determined baseline rate. The deceleration lasts for more than 2 minutes but less than 10-minute period. The causes could be maternal hypotension, uterine hyperactivity, cord prolapse, cord compression, abruption, rapid descent of the fetal head, and also in cases of maternal seizures like eclampsia, etc. Contraction stress test. It is a test that was done routinely in the yesteryears but not very routinely nowadays. It is a test in which the uterus is made to contract, and following the contraction the NST is taken to see whether there are any decelerations, etc. In case there is no physiological contraction that is present, then in those cases we might have to start syntocin to set in a sort of a artificial sort of a contraction to look for any complication or any deceleration in the fetal heart rate. Now, I just wanted to mention this. This is more for a theoretical purpose for the postgraduate especially. Remember the interpretation for contraction stress test. The test is positive if late decelerations are consistent and present with more than 50% of contractions. Remember, in a contraction stress test, positive is bad. It's not positive that is always good. So NST, a positive NST is reactive NST, but in a contraction stress test, positive contraction stress test is pathological, and if that is present, then you will have to think pathologically and take her up for whatever planning you want to do next. So the positive CST has to be associated with any increase in incidence of intrauterine death, late decelerations in labor, as well as a low Apgar score. The CST is equivocal or suspicious if there are intermittent late decelerations, and a suspicious or equivocal CST should be repeated in 24 hours. Amniotic fluid index, I'm sure most of you present here already know how to measure, so I'll skip that slide. The normal values, this is as per the recent guidelines that you can see. Previously it was 10 to 24, but now we talk of 8.1 to 24, which is normal. 5.1 to 8 centimeter is low normal, and less than or equal to 5 centimeter abnormal, that is oligohydramnios, and greater than 24 centimeter is what we call abnormal, that is polyhydramnios. Based on the gestational age, what is the proportion of risk of oligohydramnios after 4 days after a low normal AFI. In a for more than 41 weeks case, it is 23.3%, but in a case of 37 to 40 weeks, it can be only 3.7% in a case where the AFI is more than 8 centimeters. Now, the biophysical profile, that is the most important test that is routinely done for antepartum fetal surveillance, usually done between 24 to 28 weeks of gestation. Approximately 50% of NSTs are non-reactive because of the decrease in development of the autonomous nervous system. So, biophysical profile is something that is routinely done in most of these patients. The fetal movement and fetal tone develop between 7.5 and 9 weeks gestational age. Fetal breathing movements are detected by 17 to 18 weeks, and amniotic fluid may be reduced as early as 17.5 weeks by fetal acidosis, and that brings us to the picture that we might need in some cases to start a biophysical profile monitoring in these patients sometimes quite early as well. So the components of biophysical profile in order of sequence are tone, movement, breathing and reactivity. This is the order in which the development usually happens, and the biophysical profile once monitored after 28 to 30 weeks gives us almost an equal and a good result. So the different components in a non-stress test, the amniotic fluid volume, fetal breathing movements, and the fetal tone, we will not go into the detail, and these are the components that we need to look at, and we need to look at the normal range, which will give a score of 2 each, and finally the biophysical profile is counted upon 10, and we see the total amount of score that is present. So we talked of the sleep cycle, which is around 26.3 minutes, and so 30 minutes being the time that we need to wait. The sonographic variables that develop last in gestation are the most sensitive to acidosis and would be first components of the BPP to become abnormal. So remember that, and when you are, if possible, do a full biophysical profile, which almost you need to spend 30 minutes of time in a patient doing it. So in case if that is not a possibility, then in some cases we need to shift to a modified biophysical profile as well. But to interpret a biophysical profile, these 3 lines are quite very important when we see it. The non-stress test and fetal breathing movements are suppressed when the pH falls below 7.2. If the pH falls below 7.1, the fetal tone and fetal movements both become abolished. And if this is a situation that comes up to, then we know that acidosis has really set in. The presence of oligohydramnios with all the other variables of biophysical profile being normal may reflect chronic uteroplacental insufficiency. So, the perinatal mortality in comparison with the biophysical score, if the score is between 8 to 10, the perinatal mortality would be only 1.86 in 1000, and if the score is 2 or 0, then if it is 2, the mortality is almost as high as 94 per 1000 births. So the causes could be maternal and fetal, the most common maternal cause being placental abruption. There could be also causes of AFLP as well as drug overdose, etc. And fetal causes could be fetomaternal hemorrhage, cord prolapse, ruptured membranes, vasa previa being another not very common cause but an important cause which can cause complications as well. So the interpretations we have looked at. In shortage of time, I will not go into detail of this. So, there are a few special considerations that we need to talk of, and the special considerations are usually the anomalous babies which can cause problems, usually cases of gastrocases, omphalocele as well as diaphragmatic hernias. So again, the anomalous babies which can cause problems, that is if an anomalous fetus had a previously normal biophysical profile score, a decreased score should be considered as an indication of compromise, and in case if the baby is salvageable, may be taken up for an intervention, that is termination of pregnancy by caesarean section or induction of labor, whatever suits that patient at the best. So, the last modality is the Doppler velocimetry, that is the umbilical artery, the middle cerebral artery and the ductus venosus Dopplers that we need to look at. If the umbilical artery Doppler is abnormal, if the SD ratio is more than 95% for the gestational age, if there is absent end-diastolic flow, there is a chance of 10% perinatal mortality, and if there is a reversed end-diastolic flow, the chance of a perinatal mortality is almost as high as 33%. The utility is mainly in cases of fetal growth restriction. In a case of a middle cerebral artery, the fetal hypoxia causes the brain sparing that increases in the cerebrovascular resistance, and thus the Doppler, the MCA Doppler changes subsequently. Ductus venosus gives us a good correlation with perinatal outcome, but if by the time it is affected, it may be too late, and sometimes we might have to land up with a caesarean section immediately. I would like to talk about 5 slides about consent taking and how important it is when we are talking of antepartum fetal surveillance. It is very, very important for us to listen to our patient, discuss all the factors with our patient, share with them all the information that is present. In case if the NST is not reactive, in case the biophysical profile is not reactive, you will have to explain to the patient. The patient might have to come to you for the antenatal checkup over the last 6 months, 7 months, whatever it may be. But in case you find something is abnormal, you need to explain that to the patient, you need to counsel the patient adequately and respect the decision that they make at the end of your counseling. You have to make this completely medico-legally sound for yourself. You know, in today's day, because we obstetricians deal with the mother's life as well as the fetal life, and if any complication happens with either, we might land up in complication. We used to talk of a healthy mother and a healthy baby, the 2 arms, important arms in obstetrics, but now I think we have got a 3rd arm also added on, which is a healthy obstetrician, which is very, very important in today's day. You need to save your skin, because that is also very important for us, and that we are seeing in by the situation that it is coming. It is also one of the things that we need to definitely look at. So when you are taking a consent, adequate privacy is a must, and consent must be at least taken by a junior doctor. Make sure it is taken by a junior doctor. In case if you are in the operation theatre, at least by the pediatrician or anesthetist, because it is a must. Do not send your security guard or do not send your staff nurses to take consent, because the consent will be considered to be invalid. Remember, a doctor has to sign the consent for it to be a valid consent. The consent has to be signed by the patient or the guardian, the doctor and the witness. Written consent is mandatory, and the burden of proof is with the doctor, so the consent is compulsory. Remember, 2 important consents that we can also add on. One is a video consent and one is a feedback form. Now, how is a video consent important? Most of the cases we see, if they will end up in any of the complications, usually the patient relatives will later on deny the fact that the entire consent was written and then they signed it. They will usually say the doctors got it signed in a blank paper, and after that I don't know what they have written in it. So when you have taken a consent in a audio visual room, where they cannot deny later on that they have not signed it. Another important is the feedback form. We all know that the usual problem, especially in private nursing homes, is when the bill is told to the patient. I just take 1 more minute, if that is all right. Yeah. So when the bill is told to the patient, suppose on the day of discharge you say whatever 40,000-50,000 bill, till that day everything was good. On the day when you are discharging the patient, they'll come up with a lot of allegations saying this is not right, that was not right, and a lot of problems in the hospital. So remember, if you have these feedback forms that you're getting filled by the patient and the relatives from day 1 onwards, the patient will not be able to deny on the last day that things were not dealt with well, and there were some problems that were happening from day 1. And we know also a hidden secret that when a patient is getting treated from us or admitted under us, they will not give us a bad feedback. So they will of course give us a good feedback, which can also be a positive defense for us in the medical legal problem in case we land up with any. Do not go to this kuch nahi hota hai yaar approach. Do not land up with things thinking that everything will go normal and we cannot land up in complications, because complications are bound to happen when we practice in our day-to-day clinics. Put this board in the hospital, a CCTV camera, and this board, the hospital is under surveillance of CCTV, because you will see complications will be much lesser, because they'll know, the relatives will know that every action of theirs is recorded, and they will not try to cause too much of ruckus in the hospital. A favorite slide of mine: eat less, walk more, which I am definitely very bad at because I eat a lot. Do necessary, talk more, which all of us are very good at, because we counsel our patients a lot, we work a lot, but the ultimate thing that we are not good at is write more. We are very bad in documentation, and that is where we land up in trouble. So kindly do document all that you do, because that is what will only help us. I have done a lot of medical legal webinars with Dr. MC Patel. We used to do it every Tuesday 6:30 p.m. onwards, and every evening at 9 o'clock I used to think that I should stop obstetric practice because of the complications in the medical legal slides that he used to go through. Then again on Wednesday, Thursday, Friday I used to be a little careful. Again a busy OPD on Monday used to come. I used to forget everything and go back to my routine normalcy. Again Tuesday used to come, again I used to think I'll stop obstetric practice. This went on for a cycle of 1.5 years, when finally I realized it is not possible for me to stop obstetric practice. We have a lot of medical legal experts in the country who will help us in case of trouble, but remember, the best medical legal expert that you have is yourself, because until and unless you have your documentation correctly, if you have your consents properly done, no one will be able to help you in case you don't have these papers completed. So the final recommendations will be: start your antepartum fetal surveillance at 28 weeks in high-risk cases. Severe complications may require testing even earlier. Repeat weekly but bi-weekly as per the situation, and most commonly we do a modified biophysical profile, but in certain cases a biophysical profile may also be required. I would like to thank all of you for giving me this patient hearing and that extra couple of minutes. Thank you so much.
Thank you, Dr. Priyanka Rai, sir.
have extensively covered about antepartum fetal surveillance and have with your elaborate, extensive and vibrant lecture. And
Thank
you
you
have
so much.
taken care of the obstetricians also at the same time in addition to the fetus. Thank you very much.
Thank you so much, ma'am.
Any queries, please?
I'm sure no one listened to anything or they understood something because there are no questions. Thank you so much, ma'am.
Now I request Dr. Nirmala Devi Madam to present a memento to Priyanka Roy sir. Now I welcome on stage Dr. Geeta Lakshmi Madam, HOD Department of OBG, ACSR Nellore, and Dr. Lakshmi Sushila Madam, Superintendent GMH Tirupati, to present mementos to our chairpersons. Welcome on to the stage, ma'am. We have a panel discussion for this session, so please can you all stay back. This is the first panel discussion for this day. It's on PROM, VBAC and APH. So now welcome on stage the moderator for this panel discussion, Dr. Kiranmaya Madam. Kiranmaya Madam is the He is professor at Government Medical College, Vanaparthi. Madam is also the chairperson-elect FOXY No to Violence Against Women Committee from 2022 to 2025. He has been the coordinator for FOXY Dira initiative from 21 to 22. She has also been the vice president and secretary of OBGY Society, Hyderabad between 2016 and 19. She has also been the scientific convener of ASCOG 2011, Hyderabad. I welcome ma'am onto the stage. Welcome, ma'am. Now I welcome on stage the panelists for this discussion. Dr. Vani ma'am. Vani ma'am is the professor and HOD of OBGY, Department of OBGY, Srikakulam. Madam is also the member and state expert for the Committee of COVID and has also been the Honorable Secretary of IMA AMS AP State. Welcome onto the stage, ma'am. The second panelist for this panel discussion is Dr. Sudharani madam. Madam did her MBBS and MD from Andhra Medical College. Madam has worked at different medical colleges in the post of professor and HOD. Now presently working as professor of OBG at Geetham University, Visakhapatnam. Madam has also been awarded the best doctor at KG Head 2 times and she has also been examiner for both UG and PG and has also published several articles in various journals. Welcome to the stage, ma'am. And the third panelist for the panel discussion is Dr. Sita Lakshmi madam. She is a professor and HOD, Department of OBG, Narayana Medical College. Madam is a specialist skilled in laparoscopy and high-risk obstetrics and urogynecology and also in non-descent vaginal hysterectomies and has been awarded the Best Hospital Service Award in the year 2007 and has received many more awards. Welcome to the stage, ma'am. Now I request Dr. Kiranmaya madam to take over. Thank you, ma'am.
So I think we are running a little bit late and this panel stands between you all and the lunch. But I hope and I promise that as we have three experienced professors and experts who will help us to go through three important clinical situations. That is, one is PROM, which we see day in, day out, and placenta, APH, again a nightmare for us these days considering the placenta accreta and all. And the third is the VBAC, TOLAC, with the increased cesarean rates. I think again it has come into picture. So will not take more time. We promise to complete in the given time. So the first would be the PROM case scenarios, and I request Vani madam to take this, and if other panelists want to add something more, they are more than welcome. Yeah. So this is situation is for Vani madam. She is a simple primey, married life 2 years, but only thing was she was on gestational diabetes on diet with controlled blood sugars and no other obstetric disorders, with a regular antenatal care, and she presents at 37 weeks with a complaint of leaking of fluid with a Bishop score of unfavorable being 3, ma'am. So now what to do? What would be your initial clinical examination or differential diagnosis? How would you go ahead in this case?
First thing here I would like to do is to establish the diagnosis, confirm whether it is really a PROM or not. So for this, I would like to depend more on the clinical history and clinical examination by speculum examination to visualize exactly the leaking from the cervical canal or as a pool in the posterior fornix. So this is what I do for the confirmation of the diagnosis, essentially clinical and speculum examination. And rarely I do I would like to perform a PV examination because I am a bit scared for the ascending infection. So as limited as possible, unless she is in active labor, I don't go for a PV examination in the initial part of the assessment.
Yeah. So you would say that it is basically history and clinical examination
Yes.
and a per speculum examination.
Yes.
And rarely a PV.
Yes.
And we generally do not use any other test to confirm this diagnosis of
Yes.
PROA.
Yes.
Thank you, ma'am. So what not to do in this case? You have already told one thing, that is you will not do a PV examination repeatedly or to establish the diagnosis. And would you like to treat her as outpatient?
She has already completed 37 weeks.
37
There is no
weeks.
role for a outpatient treatment for this
Because
case.
she is 37 weeks.
Yes.
Now would you wait or start induction?
So even if we leave the case for a short period of 12 hours like that, so 90% of cases would land up in active labor. So if at all I want to wait, I would like to wait only for a small period for an expectant
How many
outlook.
hours? How many hours?
For around 12 to 24 hours.
12
to
to
a
24
maximum.
hours. So
Otherwise, I would like to start an induction straight away.
Okay. So though there is definitely a role for expectant management, but this ACOJ practice bulletin 18 is somewhat favorably towards starting of induction. I think today also in the morning in induction of labor, the same was mentioned. So at term, inducing labor is more beneficial to the patient in terms of neonatal outcome as well as patient satisfaction. But yes, as you said, in certain situations you can wait. And vaginal prostaglandins is effective, but when compared with oxytocin, but associated with higher rates of chorioamnitin. So if at all you induce,
If at all I want to induce, I would like to put her on oxytocin. drip.
oxytocin. Okay.
And the second line I think would be on the vaginal prostaglandin.
Vaginal, because she's leaking, would you like to go for vaginal prostaglandin or oral prostaglandin? Oral
Both
tablet.
ways it is okay. So both ways okay. So various studies have said that the success rate is equal with both. But one thing I would like to ascertain here is no role for mechanical induction.
Yes.
So that
Because
point
of
should be
ascending
highlighted
infection. Well said, ma'am. So this patient was induced with misoprostol 4 hours apart. Then after 12 hours, she has developed temperature, 100 degrees, 100.6, and pulse rate is little bit on the higher side. And uterus, liquor has drained off, looking like that, and the fetal heart is little high, and the findings are still the same. And there is no liquor, hindwater draining per vagina. What would you like to do now next? What do you suspect and what would you like to do?
Probably I have a high degree of suspicion of intraamniotic infection. I think chorioamnitis, I think is a far outdated terminology. I would like to call it as intraamniotic infection. So clinically she has a fever and already history of rupture of membranes already 12 hours and 12 hours after the induction has started. So probably it's a clear-cut case of intraamniotic infection of high degree of, with high degree of suspicion. So this also, because she has a fever, it's more of a clinical diagnosis.
Would you like to go for some investigations at this point?
So
Doctor?
I may investigate with the total leukocyte count, CRP. The sensitivity is rather good, but specificity is not so good. But however, we would like to do all this, and also any culture of the cervical and vaginal
But
swabs.
more or less it is more of a clinical diagnosis.
Is
that
more
you
of
would
a
like.
clinical diagnosis.
Sure.
So even if I would have taken a culture,
it would take
would be
time.
beneficial for the postpartum infection, not at this level.
At this level, okay. So your ultrasound might show draining, I mean liquor less or AFI being low, and then CTG also. So now such patient, if she comes at either 32 weeks, 34 weeks, 36, 37 we have discussed. Now if she comes at 32 weeks, what would you do?
So
ma'am?
between 34 and 37, we can call it as a late pre-labor rupture of membranes. In such a case, we have to individualize the case, and then expectant management also holds good. So depending on the particular case, we might go for an expected
If
management.
everything is all right, there is no
If
infection.
everything is all right, with
no
a
other,
steroid cover.
No other complications,
So with
no
a
other
steroid
obstacle.
cover and careful in investigation and observation for any intra-amniotic infection. So I would like to go for an expected management if everything else is normal.
So what would be your minimum cutoff for expectant management? What gestational age you would like to reach before you intervene?
So
Is it
maximum
34
1
or
week
37?
so maximum to a period of 1 week expectancy. So because as the latency period increases, the chance of intra-amniotic
So is
infection
it-
also will rise.
Now she has come at 32. So will you wait till 33 or 34 or 36?
So 32, I would like to wait until 34.
34.
Until
34. 34 is the cutoff.
Cutoff, yes.
So well said, ma'am.
It's an optimal time.
So we'll just go into it. Now you'll give steroids, definitely. What will be the cutoff for gestational age for steroids in a preterm PROM?
It is not before 24 weeks. So
No, I am saying 32, 34, 36, we have discussed these three.
Yes.
If she comes at 32?
32, I'll definitely give a steroid cover. And
34?
even 34 also, I would like to give a steroid cover. If it is more than 37 weeks, I don't give.
Okay, more than 37 you will not give.
Will not give.
Okay, then antibiotics, what would be your choice?
So antibiotics here, I have to speak in two terms. So one is therapeutic antibiotics, if already an established case of intra-amniotic infection, or prophylactic.
Prophylactic.
Or prophylactic. So prophylactic, I would like to say ampicillin along with erythromycin. Ampicillin initially intravenous, later followed by oral, and erythromycin oral for a period of 7 days.
Okay. That would be antibiotics. So the NICE guidelines 2021 latest also tell that there is no role for induction of labor till 34 weeks in a preterm PROM unless there is some compromise. As you have said, it is 34 weeks. Then even if you have to do expectant management, and maximum is up to 37 weeks. No role beyond 37 weeks, but you have to discuss, take counseling, they have to give consent for various maternal neonatal complications, and also it depends a lot on our NICU facilities, and it has to be a shared decision making between us and the patients. So steroids you have
So regarding
already...
expectant management and induction, it has to be a combined decision along with the patient party. And other thing regarding antibiotics, we should not give amoxicillin and clavulanic acid.
Yes.
So that is going to increase the
necrotizing
enterocolitis.
Very well said. So steroids, we are clear, but the latest Society of Fetal Medicine guidelines and the ACOG, everyone says you have to be a little cautious in the late preterm, that is 34 to 37. So if they have already received a steroid, do not repeat. If you are going for induction, then you give only a single dose. And if you are going for termination in view of PIH and all medically terminated, don't give. So we have to be little, there are conditions to be applied in between 34 and 37 weeks. So this is about steroids, but we said this is a case of GDM, though it well controlled on diet. Anything specific with steroids here, madam, GDM?
Regarding steroids in a GDM case?
Yeah, one is steroids have an impact on the mother.
Yes.
So steroids, one is the setting of infection and the setting of GDM. With these two perspectives, can you discuss something on steroids on these both aspects?
So antenatal steroids, even in case of a GDM, we have to give if she's
there is no controversy that we have to give.
There is no controversy regarding that.
But do we have to keep in view certain things, changes in the mother and the CTG?
Yeah. So because she has GDM case, I have to admit her. So definitely. And then we have to do blood sugar estimation more frequently for a period of 5 days or after 72 hours after the last dose of the steroid. So that is one point. And then careful assessment for intra-amniotic infection. And we have to be very careful in interpretation of the total leukocyte counts.
Yes.
So because while giving steroids, the leukocytes might increase until 15,000. So it will not mean
30%.
an intra-amniotic infection.
So that point we have to, one is that leukocyte count increases even without infection with steroids. And then the blood sugars, they increase even in a normoglycemic patient and definitely in a diabetic patient. So 5 days, if she's a diabetic, they elevated for up to 5 days after the first dose in diabetic patient. So these fluctuations and adjustment of the, if she receives insulin and all, and the counts also we should interpret in the backdrop of steroids.
Yes.
When we are, that's the point that I wanted to make. And the requirement for insulin is highest 9 to 10 hours after each dose of betamethasone. And if we treat with antenatal corticosteroids, levels, as you have said, have to be carefully monitored. Now, tocolytics.
And regarding steroids, I would like to add a point.
Sure, ma'am.
So we have betamethasone and dexamethasone. Whatever preparation is available in our country is only betamethasone phosphate. It is not acetate phosphate.
Not acetate phosphate. So it is
with
dexa.
in that background, dexamethasone would be the choice in our country.
Yeah, that is the government, even in government NHM guidelines also, and supplied also is the DEXA. We are using DEXA only. So
DEXA.
betamethasone, important point. So tocolytics, ma'am, what is the exact role of tocolytics? Suppose she's at 32 weeks and you are waiting.
The role of tocolyte is only for a short-lived, only for the effect of the of the steroids to happen.
That's all.
So until
No more.
that-
No more.
It's not
Yes.
beyond that.
So therapeutic tocolysis is not recommended. It's only while you are giving steroids. That is the only duration that we need. Magnesium sulfate.
So
Role
if
of
the
magnesium
delivery is
sul-
imminent,
No,
delivery
the role of magnesium sulfate in
neuroprotection and
neuroprotection.
prevention of the white matter damage, it has a definite role.
And maybe as a tocolytic also.
I think it is more in the terms of neuroprotection rather than tocolysis.
What will be the cutoff age which?
So anywhere between 32 and 36 weeks, I think it is very, very beneficial. If we
Less
think
than-
it is
yeah.
imminent, the
30
delivery is
less than,
imminent.
the
yes.
guidelines say it is less than 32 weeks. Ma'am. If it is less than 32 weeks, there is a definite role for magnesium sulfate to give as a neuroprotection. Again, the protocol will not go into it because of lack of time. You have very well covered the antibiotics about ampicillin, erythromycin, and the other. This is as per RCOG and also ACOG practice bulletin. This is the recommended antibiotics. Now, when will you stop this expectant management? What are the conditions which require immediate or your decision to deliver, even though preterm?
If there is any evidence of intraamniotic infection, yes, it has to be terminated. Or after the steroid cover is over and if you are confident that the maturity has happened. So these are two things. Or if at all she bleeds, so we should have a suspicion of placental abruption. You have to terminate. And if the metal condition or the fetal condition, both in the form of tachycardia or non-reassuring fetal heart, you have to terminate.
Sure. This I think we have covered. No to mechanical. No to mechanical, yes to oxytocin. Amniotomy doesn't apply here. Again, misoprostol and dinoprostone gel. Now, in the previous case, she went into dry labor. Most probably, you would deliver her by a cesarean section. You will not go for a further trial.
Yes.
Yeah. So now, totally absent LICA. What difficulties you expect? What techniques you use while, anticipate and handle the
So
difficulties?
definitely technical difficulty would be there. So between the presenting part and the myometrium, there is no space at all. So therefore, extraction would be difficult in such a case. So you may have to be technically sound to extract the baby. So probably Patwardhan method also might be required.
Extension of incision if at
Extension
all
of
required.
incision, yeah. So that might also be required. It's a technical difficulty.
And
basically.
again consent and counseling again plays a part here in case of any injuries or, to the fetus especially. So definitely it is one
So
of
I
the
think
difficult situations.
in this particular situation, a senior obstetrician would be better handling the case.
Yeah, anticipation, dealing with that and counseling. All these things are important and immediate neonatologist attention. Thank you, Vani ma'am. I think we have completed the discussion with our expert. Now we go to another real nightmare. I think Dr. Sita Lakshmi madam, any one of you, whoever has chosen to deal with this topic. So this is two case situations we'll discuss. One is very elective kind of thing. 3 previous cesarean sections already confirmed by ultrasound at 26 weeks, no other comorbidities. Now, ma'am, how would you prepare for this case and outlines of management or protocols? First of all, what is the terminology that we are using now?
Coming to the terminology of adherent placenta accreta spectrum is termed as morbidly adherent placenta, or in some countries, in the Europeans, they call it as pernicious placenta previa with accreta, and there can be a, depending upon the adherence or invasion, and they can be termed as morbid adherent placenta or increta or pratkita if the trophoblastic villi perforates through the serosa and
Yeah.
includes
Ma'am,
the
can you
vascular
tell our
tissues.
delegates what the new FIGO classification is about
Yes,
placenta accreta spectrum?
depending if for the classification, the includes the adherent placenta type 1 and type 2, where in type 1, depending upon the trophoblastic invasion, the trophoblastic villi densely adhere to the myometrium without the decidua, and it is called adherent placenta type 1. And then type 2 is, it is the invasive placenta, that trophoblastic villi invade the myometrium and directly, and the percreta means it it perforates through the serosa and involves the surrounding tissues, vascular channels, and the surrounding pelvic
Yeah,
tissues.
either serosa, bladder or parametrium. That is
yes.
ABC in 3.
Yes.
So, which investigation would you, I mean, ultrasound is there, Doppler is there, and then MRI is there. So what is...
Ultrasound is the best imaging modality, which
Very
is
nice.
available, cost effective, cheap, available everywhere. So the results with the transvaginal sonography or MRI is mostly good with the expert radiologist. So the only location differs with the cancers vaginal, this TVS, and with MRI it's good for posterior presentation or some involvement in the percreta group, where the, and for the mapping the invasion of the placenta to the surrounding tissues, we can opt for MRI. And power Doppler with the 3-dimensional study is good to know the placenta, and the mapping can be done with the MRI before operation. With the radiologist and the operating surgeon can combinedly can see the placental mapping to formulate the surgery and without causing any damage to the fetus.
Thank you, ma'am, for elaborating on that. There is another index that which we are reading these days, you know, in the current, anyone of you can...
Accreta index.
Yeah, placenta accreta index.
Is useful for the diagnosis. It includes the number of prior sections, abnormal placentation, or any prior classical section, or any prior endometrial ablation, or any uterine surgery scarring. That will all include this.
So, what is the cutoff for this, ma'am? Like, what is the index when you call, I mean, when it is in favor of accreta?
Accreta, when it is accreta or percreta, there is a definite indication.
The score is more.
Accreta can be managed. But when coming to the percreta or increta, the hysterectomy should be planned. Elective hysterectomy, elective scheduled hysterectomy.
Yeah, we'll come to the delivery, ma'am, right now. So, such a case which is stable, diagnosed, and supposing yours is a tertiary institute, when will you opt for the time of delivery, optimal time?
When we know the diagnosis antenatally, transvaginal sonography, we plan and see the senior obstetrician also.
When is the, at what gestational age?
If about the gestational age, if the patient is silent, without any comorbidities, without any bleeding, we can wait up to 36-37 weeks. Or comorbidities, any history of bleeding, we have to expedite the treatment, and after 34 to anywhere between 34 and 36 weeks,
yes,
the steroid cover, we can admit the patient, we can plan for...
So 34 to 36
weeks. Now it
depending
is,
on your,
yes, ACOG can recommending can wait up to 37 weeks also. But if there is any emergency impending, we can take for the surgery, and we can wait, and with the capacity to maintain if there is any unintentional surgeries are mandatory.
Yeah. So skin incision, what
Yes,
skin incision would you like to take?
Midline vertical incision and
Uterine incision?
midline incision, midline vertical incision, inspect the pelvis and abdomen or any peritoneum and all. Go for the if we already mapping is done where the for the placenta localization and the fetal presentation, and then go to vertical hysterectomy and then go up to the top, and sometimes we can, if there is any bleeding after delivery of the baby, any partial separation of the placenta, don't touch the
Yeah,
placenta.
that is the most
and
important
stays-
message. So go for the classical or upper segment above the placenta. Don't touch the placenta. Take
Take
a
away the baby through fundal incision.
transfundal. Yeah.
Keep 2 stays, 2 sutures,
Hmm.
and the amniotomy done, and come down by clamping and cutting all the ligaments, round ligaments and all.
Yeah,
Look
this
for the hemoperitoneum.
perfect, ma'am. But while going ahead with hysterectomy, do you suggest any, optimization or lessening of the blood loss? Because we
Yes.
see
All adjuvant therapies like arterial occlusions, internal arterial negation, all these can be
Available.
planned in an effective way, and anticipating all the problems. we
So
can
right
give
from
this-
aortic compression to aortic
Yes.
clamp of Pili-Sir, which we have seen, bilateral uterine artery ligation, balloon tamponade if you have
Embolization.
interventional urologist.
Yes.
So all this,
Prophylactically or during surgery.
so
can
there
also
there has to be one method of reducing the
Blood loss.
perioperative blood
Blood
loss.
loss.
What method you use is up to your convenience and availability and all. So these are the FIGO guidelines. So you can see in a higher center with multidisciplinary team, blood products, capacity to perform complex pelvic surgery, intensive care facilities, senior anesthetist, elective procedure, and even deliberate cystotomy and excision of the involved bladder, and then urologist, neonatologist, vascular surgeon, interventional radiologist, blood bank officer, team, intensivist. This is the level of, need that we may have. So, and we need to have, as you have told, accurate prenatal diagnosis, mapping, then careful meticulous surgical planning, and the checklists and good communication skills and very good documentation. So these are the FIGO checklists. Yes, Vani ma'am. I just go through this checklist. Here you can see intraoperative plans, the hysterectomy tray, cystoscopy set available, cell saver, neonatal team present, experienced surgeons on site. These are all the checklists that FIGO tells us when you are dealing with a placenta aggregata spectrum.
If at all we want to go for some conservative approach in a rarest case, we have a triple P procedure also. Perioperative mapping of what exactly placenta is lying, where exactly is lying, and then uterine artery embolization just before, and then also partial myometal resection.
Yeah, that is the
In
triple
combination
P.
is called triple
So
P procedure.
the case that we have discussed just now is an elective kind of situation. So I'm sharing with, yes ma'am, you wanted to.
Okay, we can go for this conservative management also. Suddenly, if the patient develops hemorrhage or pain or sepsis or something warrants for opening up the abdomen, then we may land in trouble. But can be done, but without any
There
without any
is a
problem,
place and
with careful
time
watching
and
and
expertise.
follow-up.
So now this is a case which had presented with in our hospital. She was previous classical or rupture case, suspected rent repair done 10 years back, landed with only a diagnosis of central placenta previa, suddenly went into shock. So no blood, no pulse, no blood pressure. So he had sudden pain, giddiness, pallor, and absent fetal heart. Now what could be the diagnosis? Obviously, mic, madam. Use mic.
Can be a percreta or rupture
Yes.
because of their history of 3 previous cesarean sections, 3 sections with abnormal presentation. It can go for rupture or percreta,
This
including
was-
all the
yes.
vascular
We
channels.
had
from
to
the-
open up
Yes.
immediately after resuscitating her as much as we could. This was a placenta extruding out of the uterine wall and eroding broad ligament till pelvic wall. So it's a FIGO classification. If we say as per classification, it would be
Yes.
3C. So next we
Plan
have to
for
go for
plan for
hysterectomy.
retrograde hysterectomy.
Total or supracervical in placenta aggregata?
If possible,
Total.
If not
as
pars,
much as
subtotal.
possible
Yes.
because we have to go below the placenta. So we had done hysterectomy. Again, post-hysterectomy, still we had to deal with pelvic hemorrhage because that right uterine we could not identify and it was retracted. So we had to do intra-iliac artery ligation, and also DIC has set in, and we had to also deal with massive hemorrhage and massive transfusion protocol.
Sometimes packing can be done.
Yeah, so many things. Because
Can be
situation
inside
will be
the pack or
situation will be out of our hand. We'll be running with time and blood loss. So we need to be very well aware with massive transfusion protocol, how to give, and the complications of massive transfusion, hypothermia, then acidosis, then electrolyte imbalance, and also the blood transfusion guidelines in pregnancy. Because many of the times these are the doubts that we have in obstetrics, when to give, when not to give. So this patient survived. We had to give 16 plus 15 blood and blood products and inotropic support. She started recovery 36 hours after initial catastrophe. Finally, she survived. So that was an emergency. But it was a tertiary institute. We could mobilize urologists and senior obstetricians, blood and everything.
All
So we could
multidisciplinary
manage.
team on call.
So there can be further non-ideal situations. Like first is what I have told. Then suddenly scan, there is nothing given, it is upper segment. Sometimes we can't rely on all the scans. Suddenly when you open up the vascular, the lower segment is vascular and it is invading into the serosa and placenta percreta or accreta stays on your face. Or in a district hospital, now they have delivered the baby. Now whether to try to remove the placenta, that will result in a
Don't meddle with the
torrential.
placenta.
Yeah. So what can we do in that situation?
Don't meddle with the placenta. You call for the help for the gynecologist, all ICU, blood bank and then if it is not possible for you, close the abdomen, send the patient to a tertiary care center.
Ma'am, you have given the perfect answer, I think, for all the juniors here. Don't go into heroics. So it is nothing wrong. Even your international guidelines, protocols all say don't meddle when you are not ready. So if you inspect and you think it is really invading, then you can maybe get the attendants inside, show them and counsel, and then close the abdomen, accompany, send someone or you go along with the patient to higher center, but after making sure
somebody
everything
was
is in
telling
place.
before now.
Yes, you keep them ready, inform them and then accompany. Then if you have everything ready, then maybe you can. Otherwise, sometimes you have given an incision, delivered the baby, then don't meddle with the placenta, clamp, cut cord close to uterus without meddling and then transfer to the higher center. Because many a time once one of our senior obstetricians in a district hospital, even in Hyderabad, they landed with this situation. She didn't know that it was accreta, then meddled with the placenta and patient had expired and she had to face lot of, lot of mob kind of situation and all.
So can I add
Yes,
something
ma'am,
here?
we have 1 minute for this case. Please add, both of you.
So I think all obstetricians should be asking for the location of the placenta and invasion of placenta along with the anomaly scan. For all
And they
cases of
should check for
post-cesarean
themselves
pregnancy.
also.
Yes. So because by 18-20 weeks, good sonologists can comment on the invasion aspect also. So I think all obstetricians should be asking for the invasion part and the location of the placenta in all post-cesarean pregnancy mandatorily at 18-20 weeks.
Exactly, ma'am. And one point is whenever there is central placenta previa or anterior placenta previa low lying with a previous scar, you ask for an expert radiologist's second opinion. Nothing wrong with that. Yes, ma'am.
Cesarean scar pregnancy may
Yes.
not mobilize, but whereas coming to them in the low-lying placenta can be mobilized even though it is diagnosed in the early TIFA.
Cesarean scar pregnancy, again the current thought is if it is conservatively managed and if it continues, definitely it will land in your accreta.
Because the villi
Yes.
are permitted, cannot
Thank
can
you,
be
ma'am.
mobilized.
Thank you for your wonderful inputs. So we go to the TOLAC or VBAC, the third case scenario. So she's a case of previous cesarean. First is for a non-recurrent indication, that is for breech. Now there are no other medical obstetric complications. Now the patient at around 32 weeks, she tells you that I want a vaginal delivery. So now the ball is in your court. So how will you approach, counsel and manage this patient? First of all, ma'am, what is the terminology? We say VBAC, TOLAC. PRCD, ERCD. Can you just elaborate on this terminology?
TOLAC means trial of labor after cesarean section. It's an attempt to deliver vaginally in a woman who had previously delivered by cesarean section. If it is successful, it
Becomes
ends
a
up
VBAC.
in VBAC, vaginal birth after cesarean.
Yeah.
But if it fails, it ends up in emergency repeat cesarean section, delivery. And PRCD is prophylactic
Planned.
repeat cesarean, planned
Elective
repeat cesarean delivery.
section.
Usually
These terms-
done at 39 weeks of gestation.
So counseling, any inputs as an expert and senior?
Once patient has undergone cesarean section and now she is pregnant, we can counsel her the mode of delivery. And we have to tell her about the risks and benefits of trial of labor and also elective repeat cesarean section. And the more where to deliver the patient, where all the facilities
What
are
is the
available.
dreaded complication for us or for the patient?
That's what. In TOLAC, the dreaded complication is scar rupture. That is 0.5%. So you have to explain to her about that. But the advantage is also that she can deliver vaginally in future pregnancies and
the
cost
dangers.
effective and early recovery is possible in this. Whereas in elective section, rupture is nil, and patient, if she becomes pregnant again, repeat sections may lead to placenta previa, adherent placenta,
Yeah, this
and
is
other surgical complications due to adhesions.
So there is again a shared decision.
Yes.
I would like to add one thing. So,
Yes.
so regarding counseling, so it should be a positive counseling.
Yeah.
So actually
It should not
benefits
be a
should be
negative.
highlighted more. So if you are constantly speaking of rupture, no one would
Yes.
accept in the
But at the
counseling.
same time, it should not be a false kind of assurance and.
No, it is not. It should not be false assurance,
Mm.
but the benefit should be more highlighted.
Yes. The
So only
repeat
then the
section
patient will be
complications
accepting.
are also not less. Anesthesia, not just Acrita, anesthesia complications or the infection, the bleeding,
Everything should be
mobility,
informed,
everything.
but the actual benefit of vaginal birth should be emphasized more.
Yes.
Only then the patient will have a good
Anyway,
acceptance.
patient is already willing for a TOLAC.
Patient is
So there are some predictive models for successful TOLAC, but I don't think anybody is really using it. So again, gestational age for intervention. Now both have decided that we'll go for a TOLAC patient and yourself, and your center is well equipped. You have neonatal monitoring, surveillance and everything. And when would you like to really intervene? 39, 40 or 41 weeks?
Usually, delivery is planned at 39 weeks. If a patient goes beyond 40 weeks, induction should be
In other words, would you wait for a spontaneous onset of labor
better to wait for spontaneous onset of labor up to 40 weeks.
up to 40?
Beyond 40 weeks, induction, there is risks of rupture is more, and also success is less.
Less. And what is, if I ask you, what is the single most important factor in pre-labor assessment to predict successful VBAC?
Previous vaginal birth or previous VBAC.
That is one factor, ma'am. More than that, yeah, that is one important factor, which is, a positive thing.
Only one lower segment cesarean section.
Yeah, one
vertex
lower
presentation.
segment. Now present.
Bishop score is
Yes,
good.
yes, yes.
Cervical,
Cervical
and station
score.
of the head should be below.
Yeah.
Then only spontaneous
So-
labor onset. These
So
are all
Bishop score, favorable cervical score and smooth onset of labor, descent of head. These are all the things which really tell us she may deliver vaginally. And again added is
Previous
she has one
indication for
vagina.
non-recurrent indication for section.
All those are there.
Usually
Anyway, all those factors we consider before giving TOLAC. So what about scar thickness, ma'am?
Nowadays we are doing ultrasonography for scar thickness. There is high risk if it is 0.6 to 2 millimeters. Yeah, and incidence of scar
So
rupture
you will
is
take
more,
into
but if
consideration.
it is more than 2.2 to 4.1, there is negative predictive value for the scar rupture.
Yeah.
But there is no cutoff value, and we cannot completely rely on the scar thickness.
Sure. So we cannot completely rely. Even though scar thickness is good, again, it is no guarantee that this is not going to go for a scar
Health and elasticity of the scar plays much role rather than the thickness.
thickness.
Clinical examination is the best one.
Okay, for scar tenderness and pulse rate and all. Okay, now spontaneous is what we all agreed, but is there any role for induction in a TOLAC, madam?
Section of labor, if it is, if we don't know the previous scar or cervical
Suppose your patient, what we have discussed, doesn't set into labor at 40 weeks.
if the Bishop score is more and vertex presentation and no other complications, we can go for induction with mechanical methods.
Mechanical method, very nicely told. So, but that means definitely when you are using prostaglandins, the risk of scar dehiscence is going to increase, even with oxytocin for augmentation. That is the message. You may augment with oxytocin, you may use PGE2, misoprostol is definitely
Misoprostol is contraindicated.
but definitely prostaglandin either or even oxytocin are going to even relatively increase the risk of scar dehiscence. Mechanical method is the accepted method. So this is what it is. The risk of rupture is spontaneous labor is, if it is 4 per 1000, with augmentation with oxytocin it is 9 per 1000. And you see with prostaglandin it is 14 per 1000. Mechanical again with or without is lesser, like with oxytocin. So IOL in unfavorable cervix, if you are meddling with unfavorable cervix trying to induce 3-fold increased risk of uterine rupture is there, and with prostaglandins 3 times increased risk of uterine rupture. Augmentation again, there is some greater risk of uterine rupture than was spontaneous labor. So mechanical is important. Again in the morning we were discussing again with what is the inflation, I mean the distension that you do, 30, 40, 50, 60. Today they were saying about 75 also. The balloon.
Balloon, catheter.
How much you want to distend?
30 ml.
30 is what
30
is.
to 50 ml.
So, but in the morning, there were Dr. Samadram was, I think, we heard
He
him
said,
talking 22
single balloon and double balloon.
double balloon. Even Foley's 22F, he was saying 75. And I heard our professors from Tirupati, they were telling 60. But anyway, this doesn't have any added pharmacological effect on the scar. So, we discussed this. So, I think it is understood that we should have a very good intrapartum monitoring protocol. Whatever it is, and labor analgesia
Epidural analgesia is preferred. If there is any increase in patient is asking for more doses of pain relief, you have to suspect rupture.
So she has to be on continuous CTG monitoring and CTG trace. What is the first sign of scar dehiscence?
Non-reassuring CTG with the decelerations.
I have seen one patient with severe bladder tenesmus and you know that urgency and all. So the postgraduate was going on catheterizing, but we just took up and it was scar dehiscence. So again, technically and theoretically, ECV for breech is not contraindicated, but I don't think we are going to do this for frequently for a post-cesarean. Amnio infusion is also not contraindicated. Epidural is accepted, and these are the terms again: crash cesarean, immediate cesarean, urgent cesarean, and emergency cesarean. Are there any difference between these?
In the event of any complications during TOLAC, we have to take her to cesarean within 20 minutes.
Anyone
So
differing? Yeah, 20. I mean, there is a crash, there is immediate, there is urgent, there is different terminologies. So, is there a difference? Let's see in the next slide. We used to, when we were PGs, I think we all used to explore the scar after TOLAC, which is stopped now.
There is
There's
no role for
second opinion about
routine.
that. Would you like to assist the delivery in the second stage? By forceps or vacuum?
second stage should be cut short by outlet forceps or ventilation.
Yes, there is definitely a role. So again, this is, we all know. We had one case which went on completely till full dilatation and +1, and suddenly it stopped at +1. And we could not make anything out on scan also, but when we opened, the whole rest of the body was outside, it was IUD, stillbirth. Then the rest of the trunk and whole, everything was outside the uterine cavity, only head was sitting still there. I mean, we can never know. It went on smoothly till full dilatation. So this loss of station, instead of loss of station, even not progressing as much as you think it should, also should give a very clear cut. So this is regarding crash, and so crash section is, they say, 9 minutes. So you should have a facility to do a cesarean within 9 minutes if you are giving a TOLAC. Or your labor room delivery LDR concept has a direct passage into your OT, and you prepare her as if she is for theatre, and epidural is in place, and now you have a doubt of scar dehiscence, you just wheel in and do a deliver, take out the baby in 9 minutes. So that is crash. So immediate is little time is there, 15 minutes, and urgent is what we do for abruption or, you know, fetal distress, protein regular fetal distress and all. So these are the, I think that ends the discussion.
I just want to add one.
Yeah.
So the average time between the scar dehiscence and scar rupture is
Yeah.
on an average 30 minutes in various studies. So that is why in any center should have that facility to go for a cesarean section within 30 minutes.
Within 30 minutes.
Only
That
then
is
you
what.
can offer a TOLAC.
Yeah, at least 30 minutes. No more, not more than that. I think, ma'am, would you like to, each one of you, give 1 or 2 take-home points? We have just 2 minutes left so that we can conclude. Thank you for wonderful inputs.
I think you can summarize the whole event.
You want me to summarize?
Yeah, please.
Yeah. So PROM is 37 weeks. I want to give this message that don't wait for expectant management. Better induce, that is giving a better result. So that is more accepted. Because in our district hospital, which is now a new medical college, they have the habit of leaving the PROMs for 12 hours. So most were usually landing in cesareans or infections or fevers and all. So induce as quickly as possible once they cross 37 weeks. Then if you are going for an expectant management in preterm PROM, don't go beyond, don't induce before 34 weeks if there are no other complications. 34 to 37 is the period. Then give steroids, but carefully after 34 weeks, antibiotics, and then the steroids effect on mother and fetus also is something to think about when you are taking your total counts and all. If she's a diabetic and all on the sugars, then infections, and then choice of antibiotics. Tocolytics, no therapeutic tocolytics for long. It's only till you cover the steroid dosage. Then comes PAS. I think we have got wonderful messages. Don't operate wherever you want. Your preparation is most important. Your team is important. And when you inadvertently land with a PAS, don't be, just because you have opened, don't go and complete the whole procedure. You can close at the level of the skin. You can close after delivery of the baby with a classical section, and without, don't meddle the placenta when you are not ready. And have a total team and use one method of reducing the blood loss when you are going ahead with a hysterectomy. So that is either aortic compression if you don't have anything, or aortic clamp, or internal iliac artery ligation, or balloon, whatever method. And then coming to the TOLAC, I think it is really not easy to give a TOLAC unless your center is fully equipped and your patient is well educated, counseled and accepting, and it's a shared decision. You have a very good monitoring protocol, neonatologist, and the ability to do a crash or even emergency cesarean section as quickly as possible. I think that ends. Thank you, ma'am. Thank you so much to all the team Tirupati. I see my teacher Padmaja madam here. Good afternoon, ma'am. Thank you so much for this opportunity.
Thank you, ma'am, for an elaborate discussion on PROM, VBAC and APH, how to manage. Now I would like to invite Dr. Mahapatra sir and Dr. Padmanya madam to come on to the stage to present mementos to moderator ma'am and all the expert panelists.
I request the audience to stay in the hall for 2 minutes. Next session we are going to felicitate Madam Dr. Ramalakshmi Madam. I request the audience to stay in the hall, please.
And following this felicitation, we'll break for lunch and the next session will start at 2:20 p.m.
Next session will be the felicitation of Dr. Ramalakshmi Madam. I would like to invite Dr. Ramalakshmi Madam onto the dais on behalf of Talks and Department of OBG. We are felicitating Madam. Madam is, they are sponsoring the sessions since the morning. So morning 2 sessions what we had till now 9 to 1 o'clock, Madam is sponsoring. A brief introduction of Dr. Ramalakshmi Madam by Dr. Aruna, Department of OBG, Assistant Professor. Thank you.
Good afternoon to all. I am very happy and I feel it is great privilege to me to introduce Dr. Ramalakshmi Madam Garu on the special occasion. And Madam Garu is sponsored. Madam Garu sponsored the morning 2 sessions of scientific session. Born in 1948 at Lakshmi Reddy Garipalli to Mr. Krishna Reddy Garu and Mrs. Kuppamma Reddam Garu, studied MBBS at Osmania Medical College, Hyderabad, and did government service of 22 years. She established Dr. Ramalakshmamma Nursing Home 1982 at Chittoor, and she practiced OB-Gynec with passion and determination, conducted so many deliveries and many gynecological operations, and she learned laparoscopic surgery at the age of 58 years. With her only basic degree, she has presented many papers in Foxy national conferences and has been awarded for conducting higher number of tubectomies under National Family Welfare Program. She is a life member of Indian Red Cross Society and participated actively in many number of social activities, providing monitoring support to the fatherless girl children for their education in 5 schools since 30 years. She has passion for teaching and loved by many nursing students very dearly, given many lectures on women empowerment and motivational lectures for women employees at many institutions. She has written novel on her own life and her mother role in her life as O Talli Ame Tanya. She is an established writer and very good speaker. Conducted many health camps in rural areas and educated many women regarding the use of sanitary napkins. She is in process of establishing geriatric hospital and also a home for the elderly. Thank you, madam. Thank you for sponsoring the session. And now, felicitation for the Ranulakshmi ma'am will follow. Thank you.
Thank you, madam. Thank you so much. It's a great felicitation to great human being and great personality. Next, lunch will follow. So next sessions, afternoon sessions, the theme will be on law and OBG. It will be quite interesting. And in day-to-day care, we are going to get so many problems and so many queries where eminent speakers are there where you can clarify your doubts. And I request all the delegates to come sharp by 2:20. The first session will be on MTP Amendment Act by Dr. M.C. Patel. Thank you so much.
Sound also.
साउंड तो पहले
हाँ।
स्लाइड में सर
नहीं, we'll just check sound है कि नहीं. Okay, we'll-
पोडियम का
Yes. Yes, yes.
प्लग करके सर एक बार उसको कनेक्ट कर दें.
हाँ. नहीं, इसमें से नहीं लेता है क्या?
नहीं.
हम लोग EMI से नहीं लेता
नहीं
है.
HDMI से सर अलग है. वो HDMI से तब आता है जब टीवी को अपन HDMI कनेक्ट करते हैं ना, वो डायरेक्टली आ जाता है कि वो HDMI में वो ऑप्शन आया था ना.
और ये आपने कंसोल में लिया है, फिर स्प्लिट डायरेक्ट स्प्लिट करते हैं ना, तो बताइए. नॉट टेकिंग.
वो स्क्रीन चल रहा होता है. वो जब वो 14/40 वगैरह जब लगता है ना,
हाँ, तब नहीं,
तब वो
या तो
straight चलता है.
दो तीन में ऐसे दिया है तो नहीं चलता है. बहुत बार वो डाउन हो जाता
नहीं, ऐसा तो हमारे
है. नहीं, बिकॉज यू आर टेकिंग डायरेक्टली फ्रॉम हियर, इट इज गोइंग टू कंसोल ना. वो लोग क्या कंसोल में फिर वहां से रूट किया.
अच्छा
कैसे होगा?
बराबर है. फिर वो
Then
कहीं
it
से
will
बीच
not,
में
हाँ.
कनेक्शन की लूज हो गया तो फिर
हाँ.
बाकी सारी चीजें बंद
बाकी
हो
सारी
जाती
चीजें तो उठा नहीं पाता है ना. ये इतना छोटा कैसे सबका उठाएगा? दैट इज आई चेक.
हैं.